Again, welcome again on the Balkan endovascular course, the biggest regional endovascular therapy meeting. And I would like to break the tradition and to start on time instead of waiting too much. Of course, the let's say official opening ceremony will take place tomorrow at 9 a.m. And of course, we are going to start with also important topics today. It's not a pre-Congress. In fact, the Congress is starting. I would like to thank you, Iris, Anna, all our friends from all over the world. We are going to have experts from 3 continents. And this is really huge support for our local endovascular society. We are trying since more than 10 years to spread endovascular way of thinking. So probably one of the main targets of this meeting is exactly that, to think endovascular. To think endovascular, of course, without putting apart all the other options. So, but to think endovascular first. And of course, without the companies supporting us, it would be impossible to perform such educational, very important educational. I think the accent will be on educational. And because of that, we are going to have simulators, hands-on session on one of the parallel rooms. And of course, we are going to have live cases. Hopefully, all live cases go smoothly. And this is also very important. I like very much this, that we keep the live cases strategy. So not to, let's say, to remove the live cases like in many other conferences. But nowadays, after the COVID, I just came from the TCT. They were very happy to have 2/3 of the audience compared to the before COVID time. So we are together again, and hopefully never to lose the connection like the last 2 years happened. Okay, thank you so much once again. And with no more, I'm giving the floor to Dr. Professor Nikolov in order to start with the first presentation of the meeting. It's regarding the vascular closure devices. Absolutely by purpose, we together decided to start with vascular closure devices because in case we don't have notion about how to close a puncture, because we have spoken, this is endovascular, so it's not cutting, no bleeding, it's a puncture. But we have punctures from 4 French, like some peripheral interventions, to 24 French. So we have to know how to close endovascular access. So, Professor Nikolov, thank you.
Thank you, Professor Petrov. And once again, I welcome you to this year Balkan Endovascular Academy. And I start with closure devices, suture-based closure devices. So I want to present you the Perclose ProStyle suture-mediated vascular closure device. This is a suture-based technology. It's a single monofilament polypropylene suture, I think 4 or 5 nil. And for puncture site 6 to 8 French, we need only 1 device. When we decide to use larger French sheets, we are obliged to use at least 2 ProStyle devices, and we can close punctures from in arterial system from 5 to 21 French or 24 outer diameter, and we can use it on of course in the venous system. We can close punctures up to 24 French sheets and puncture site. So I want to talk a little bit more about the access. I always do my EVAR cases or TVAR cases when we have such. I always do the puncture with ultrasound guidance. It's cheap. It's very easy to be done, and we have no X-ray, no contrast media, so we can see very clearly the common femoral artery. In some cases, we have a very high bifurcation of the common femoral artery, and the ultrasound helps us. We can see calcium, not to puncture in these zones, in order to device to work, to suture the artery, to close the defect. And of course, with the ultrasound, we can see clearly the vessel we want to puncture, so no wrong vessel puncture will be done with such a device. It's always, if the specialist is trained, it's very easy to obtain such access on the common femoral artery under 45 degrees. And this is one of my cases, EVAR case. I start with the ultrasound guidance. We puncture the artery, and we begin with a 7 French sheet. I make an incision, as you can see, to make space for the wart sheet. This is the first ProStyle device over the wire. We remove the wire, as you can see, and then we should push that and obtain active bleeding. There is a certain feeling when you go through the whole arterial wall, and the bleeding is very good then. This is the first step, 30 degrees left, the anchor, and this is the needle deployment. In some cases, we usually do this with local anesthesia. The patient can feel the needles, but no problem, it's just a temporary feeling. Then we should take out the threads. As you can see, here are the threads, 2 threads, one with white marking. Then we reintroduce the guide wire. And these threads, we put one in the left, one in the right. We use instrument. As you can see, the instrument has plastic tubes, not to damage the threads, because they are very gentle if you squeeze it with a bare instrument. And then we put the next device, 30 degrees to the right. This time, we repeat and this is the sheath. As you can see, this is a central sheath, 18 French. No problem, we remove the sheath and we close the puncture site by gently pushing the threads, first one, and to anchor the knot, we use the white marking. This is the puncture. This is the devices that cut the threads and leave only the knot. This is the final result. Totally percutaneous EVAR procedure. The same patient, we have to use axillary access because we have to save one of the internal iliac arteries, so we made a parallel graft technique. And this is the puncture site. I don't see it in this, but believe me, we have puncture in the axillary artery, and the 5th prog white calls that puncture site 7 French sheet. And this is something I want to show you. This is one of my patients who underwent EVAR procedure with ProStyle. After a couple of days, we have to make a femoral access for another reason, not related to the EVAR. And this is how it looks, the knot in the artery. This is the artery, and this is the knot. As you can see, here are the mustache of the threads. I'm convinced in this technology. This is in vivo. It's rarely seen. We always work and in the workshops on the plastic tubes, but it's different in a real person. The knot was very tight, no bleeding. As you can see, no bleeding from the puncture site. So the patient is okay. And I want to show you some meta-analysis comparison of MANTA and PROG White. This is from this year, 2022. And the conclusion of the authors is that there is no difference between the PROG White and the MANTA device in terms of major bleeding or other complications, life-threatening bleeding or pseudoaneurysms and so on. And another study, exercise complications after TAVI. As you can see, they divided the groups in two. When the operators have to make their learning curve, 25 cases, and when the operators are after that very experienced with 50 cases. So what's interesting is that in the learning curve of the operators, there are some complications, but when the operator is experienced, the complications decrease in half, almost in half. So more and more, when you use this device, you become more experienced, so you have less complications. With that, I thank you for your attention. If there are some questions, I'm ready to answer.
Probably quite interesting for the audience. We know that not always one device is sufficient for ordinary cases. In case there is some mild failure, not as for open switch, but mild failure. So let's say some continuing bleeding. What you can do? What you can do as a bailout?
Yeah. At first we push, but with the experience we leave the wire to the end when we are sure that we have no bleeding. And if you have the wire in the puncture site, you can, in very rare cases, you can use a third PROG White or some other closure device like angio-seal, for example, to close the little hole that remains. But this is very rare. Yeah.
Great, thank you. So, as you have understood, it's crucial to leave the wire inside. So, up to the moment the wire is inside, you have different options. Adding another suture-based device or plug-based device, and what Professor Nikolov mentioned, it's absolutely true. We can add even a plug, small angio-seal, let's say small, 8 French angio-seal. It works very well.
Yeah.
Okay, thank you. Please, Professor Nikolov, sit as a moderator. So my presentation will be extremely short, absolutely by purpose. And the purpose is that, in fact, one of the pioneers of the vascular closure devices, Professor Zvonimir Krajzer, from Houston Cardiovascular Center. He will have recorded presentation regarding the vascular closure devices, the big vascular closure devices. In fact, Nadeline have talked already about suture-based closure devices, and I will share our experience with plug-based closure devices. In fact, probably around 20 years ago, I used for the first time AngioSeal, of course, the previous version of AngioSeal. Now we have AngioSeal Evolution, the last one. And what is the principle? It's different from the suture-based device, so it's not a suture. In fact, it's a sandwich of anchor or plug that is inside from the inner side of the vessel. And it's additional, in most of the cases, a sponge with coagulation material that is in fact put in the anterior wall of the vessel between the anchor and this coagulation sponge that is put over the artery. It's probably very important to emphasize that both components of this sandwich are resorbable. So in about 40 to 90 days, we expect nothing to stay inside of the vessel. And this is very important regarding repuncture this side and so on. So after the 45 days, it's considered absolutely doable without any risk. In case we have to, this is in fact the video showing what is the procedure. It's quite easy. In fact, this is the locator. It's like a sheet that is locating in fact the tip of the locator inside the vessel in order to be sure that the anchor will be inside of on the inner part of the vessel wall. And this is the anchor itself, as you see. And in case we have to puncture before 45 days, we have to puncture on a site at least 2 centimeters away from the first anchor positioned. And this is in fact finally after putting let's say closing the sandwich, we are cutting the thread. Okay, so this is the principle, and there are, of course, because the experience with AngioSeal, it's a very long time ago, since I mentioned more than 20 years of experience of the principle. This is the principle. Of course, there are some additional refinements, but this is the principle, to put the anterior vessel wall into this sandwich in order to have the possibility to stop bleeding on such a way. In some cases, you see the deployment success is quite good. And of course, it's very important to follow all the steps and to follow also the rules to puncture on the right side. So to avoid calcium, to avoid thrombosis, to avoid subtotal stenosis. Of course, it would be nice to have some Doppler data in advance, or even to puncture under Doppler guidance. So in order to have the absolutely security about the puncture of the site. So this is our only 5 years back experience. So we have used for 1,249 puncture sites to put AngioSeal. And I have to share that we have used not only for femoral, but also off-label for subclavian or carotid. In some cases, like we are going to show you, we are using brachial or carotid direct puncture in order to put the chimney into the aortic arch. And of course, we can use suture-based device, but in case the suture-based device has failed, we can use, of course, the plug-based device without any problem, and on subclavian or even carotid off-label level. And it's also important, I have learned that about 7 or 8 years ago from an Italian endovascular guy, that the AngioSeal 8 French can be used up to 12 French puncture sheet, and it resulted true. So of course it has to be applied very gently, because if we pull too strong, the anchor that is not in fact intended for 12 French, the anchor can escape. So with a very gentle pulling, we can use the 8 French device up to 12 French. For example, for all our AAA, ever procedure, the contralateral limb insertion. We are using sheetless insertion of the contralateral limb and closing the contralateral limb site with angioseal without any big problem. You see that during these 5 years, we have more than 20 years experience. So during the last 5 years, we had only 0.1% of surgery requiring complication. Only 0.1, that is quite lower than the published into the trials. And these are, I'm switching now to large bore plug-based devices like the Manta. In our experience during the last 13 years, we have used large bore devices, suture-based, ProGlide, quite a lot, and of course, large bore Manta device. That is, in fact, the author of the Manta is in fact the same engineer like the engineer of angioseal. They are probably a little upset, but I'm telling that the Manta is like a huge angioseal, and because the principle is very similar, so it's an anchor inside and a sponge outside. This is more or less our statistics regarding our procedure, and as you can see, this is our global statistic put together suture and plug-based devices. So we had very low complication rate with both devices. There are many nowadays systematic reviews comparing plug-based to suture-based devices. Of course, both sides, both groups, they have, let's say, advantages and disadvantages. But for example, this is a right place of puncturing the common femoral artery without calcium, and this is the final result after using the right device on the right place. We have to follow all the rules to measure all the distances. More than obvious, our aim, our target has to be the common femoral artery. It means over the femoral head. So this is very important to have good baseline support for possible future compression. And it's also very important to puncture the common femoral, not only for the compression, eventual compression, but also to avoid the branches, to avoid the profunda femoris, in order, because the probability of complication in case we puncture too low is quite bigger, several times bigger. So different kind of complications. We have to be aware about complications. There are really a number of complications. That can be occlusive complications, bleeding complications, dissection complications. There are many complications, but in order to avoid them, we have to follow the rules. All these are obstacles. I mentioned already some of them: thrombus, calcium, tortuous vessels, and these are some of the complications. In most of the cases, pseudoaneurysm can be resolved with manual compression, but very concentric and very local in fact on the puncture site and the communication between the vessel and the pseudoaneurysm. So under Doppler duplex control, we have to see where is the communication, and not with the fist, but with a finger. We have to compress over the connection, even with the transducer probe. Some colleagues are compressing with the transducer probe over the right place, the communication between the vessel and the pseudoaneurysm itself. In pseudoaneurysm, this maneuver is possible and it's doable. In about 70% of the cases, pseudoaneurysm can be resolved with compression. It's not the same with arteriovenous iatrogenic fistula. This situation is requiring surgical second look, And of course, big retroperitoneal bleeding. They're requiring, not always, but in case it's really big retroperitoneal, in case the puncture is too high over the ligament, the inguinal ligament, we have to go for surgery in order to have revision, abdominal revision and vascular closure. So this is the MANTA. In fact, there are 14 French and 18 French. And with the indication of 18 French, MANTA device can go up to 25 French holes closing. And this is the principle. As I mentioned, the principle is the same. It's anchor or toggle, a suture that is connecting the anchor with the collagen, and over the collagen sponge there is a lock that is in fact put similar to the angioseal. It's put over the collagen in order to have the sandwich already very tightened on the anterior vessel wall. There, I mentioned different studies showing, of course, the learning curve is very important, and Nadeline also showed how important is the learning curve. We have to follow the rules. We have to have good experience in order to achieve, you see, more than 95% of success rate and low complication rate. One of the possible, let's say, misplacements will be in cases in which the anchor, it's not parallel to the vessel wall, but it's perpendicular. In this situation, and I will show a case, we have several cases. Of course, after putting 500 devices, we have many cases, case by case of complications, and it's very important to know what to do with complication. In case there is a closure of the plug of the anchor, and it's perpendicular or elliptical, we have to go aside with a wire and with a balloon to put the anchor again to be parallel to the vessel wall. So from this situation to go again parallel, and this is very important. This is very short video, and you are going to see that it's a very similar video to the angioseal because in fact the principle is the same. So on the tip of the locator is going the anchor, and between the anchor and the collagen sponge is the anterior vessel wall. So it's absolutely the same, and this is the schematic. And in fact, the MANTA is characteristic that the metal marker is put there by purpose. So the angioseal doesn't have any metallic part on site, but the MANTA has outside of the vessel a metal marker absolutely by purpose in order to have notion where is the MANTA positioned, and for a future puncture to avoid this place. Of course, it's better to be avoided. Okay, I'm skipping several trials, and this is complex and complicated. You see, there is, in fact, this is the marker of the MANTA, and it's subtotal. In fact, it's practically total occlusion on the level of the MANTA, and with because we are doing almost all our TAVI, aortic valve, TAVI, ever and ever cases with radial or brachial access with the pigtail, and because of that, you see that the sheet to correct this complication is coming from above, so coming from the radial or from brachial. It's 2 minutes time. Independently, is it bleeding or ischemic complication? It's very easy to go from above to cross the level of interest, bleeding or ischemic. And after crossing this site, we are with the inflation, gentle inflation of a balloon. The aim of the inflation of this balloon is not to dilate the vessel. The aim is to put the anchor back to be parallel to the vessel wall, and this is the final result. Okay, I will stop here, and more than obvious, it was ever triple A case in this situation, and you see the final, and this is the Doppler. Okay, thank you very much. It's I think the message is clear. So it's a helpful device on the right hand. Thank you so much. Probably some questions or comments. Okay, everything clear. Okay, we can hopefully we can go now. I would like to give my gratitude to all EVS executive board members for supporting us. In fact, this is a local International Society of Endovascular Specialists meeting. So I would like to thank Zvonko, Donald Tree, Jack Busquet. You are going to see all these guys, expert guys, tomorrow during the opening. Professor Lunderu, my teacher, thank you for coming. Okay, we are ready to start with Zvonko Krajzer presentation. I mentioned already he is really one of the pioneers. He is one of the pioneers of the vascular closure devices application. The vascular closure device. Professor Matthias, thank you. Welcome. Thank you for coming. Thank you. Thank you for your support. Okay, what
My name is Zvonko Krajzer. I'm an interventional cardiologist at Texas Heart Institute in Houston, Texas. I would like to thank Dr. Ivo Petrov and the organizers of BEC for the invitation to participate at this meeting. I'm truly sorry I was not able to be present in person at this meeting due to my prior obligations at work. The topic of this presentation is 26 years of experience with large bore closure devices. What are the implications on morbidity, length of stay, and cost? Here are my disclosures related to this presentation. Now, we have to go back in history, and the first EVAR device, or endoluminal abdominal aortic aneurysm repair, was performed on September 7, 1990 by a visionary, my dear friend, Dr. Juan Parodi from Buenos Aires, Argentina, with the purpose to decrease the risk of surgery and the risk of general anesthesia. Now, there are certain things that occurred in the 90s, shortly after Dr. Parodi's invention of EVAR, that were of concern to all of us. Number one, it was still a surgical procedure that required femoral artery access and repair with surgery, the use of general anesthesia, and all of those things led to pain, neuropathy, risk of infection, risk of bleeding, formation of scar, lymphocele, and prolonged recovery. So the question was, how to decrease morbidity and mortality of EVAR. Interestingly enough, one of the luminaries at Texas Heart Institute was Dr. Denton Cooley, and as it is commonly mentioned in medicine, all great minds think alike. Similarly, like what Dr. Juan Parodi did for EVAR, Dr. Cooley did for many cardiovascular procedures here at Texas Heart Institute. So with guidance and support of Dr. Cooley, we invented PVAR, or percutaneous abdominal aortic aneurysm repair, at Texas Heart Institute using 14 French sheath on June 6, 1996. Now it's important to mention that at that time, the early EVAR devices were bulky, large in profile, and required a use of 22 to 24 French sheath to deliver the stent graft to desired location. Here we can see the use of 14 French sheath to advance the device percutaneously through the femoral artery access in the cardiac cath lab under conscious sedation. Now, to be able to do that at that time, we had to use commercially available products that are shown here, and we had to modify and simplify and apply technique similarly what Dr. Cooley has done in the past with many innovative cardiovascular procedures. So as you can see here on the right-hand side, we can see a huge abdominal aortic aneurysm located below the renal arteries with pre and post findings. And we published this in the Journal of Endovascular Surgery in 1997. What is important at that time, in the United States, we did not have any of the large bore closure devices for repair of the femoral artery access site, so we had to use one of those clamps, so-called femstop, to achieve adequate hemostasis. Now, shortly after that, in 1997, there was introduction of percutaneous large bore closure devices here in the United States, and the first one was the ProStar XL, which has been approved for large bore access and repair in EU for the sheath sizes of between 10 to 24 French. There were some of the disadvantages of this device, that it requires a prolonged learning curve, and it's not nowadays extensively used. As you can see here on the bottom, we published our results using this particular device. Now, ProGlide is a 6 French suture-mediated vascular closure device that is more commonly used in the United States, not only for interventional procedures, but also for large bore access. It has a shorter learning curve. It's very commonly used, but there are certain disadvantages for large bore access, that it requires 2 devices to be used, and the technical success has been reported to be between 94 and 97%, as reported in the publications stated below. The major vascular complications have been reported to occur in about 6% of patients. Now, here are the steps as far as doing a percutaneous access and repair using ProStar and ProGlide, which are suture-mediated devices that are actually deployed in so-called pre-close fashion. It means at the beginning of the procedure, and then the access closure is achieved at the very end of the procedure. As you can see, the access site is very small. 1 steri-strip is sufficient to close the access site. Now, as far as publications are concerned related to the pre-close technique using ProGlide, here we have 2 of them that were published by us and co-workers from the PVAR trial, where the ProGlide technical success was 94%, and later in the Life registry, where ProGlide technical success was even higher at 97%. And here we see the publications related to both trials. Now, what is important when you compare this information from the publications from the ProGlide trials with surgical access repair and the use of general anesthesia? And this particular comparison is between National Surgical Quality Improvement Program publication by Gupta and co-workers and our publication from the Life registry. What we can see here clearly, that unplanned 30-day readmission rate with surgical access and repair was 7.9% versus 1.6% in the Life registry. As far as operation needed during readmission, in the NSQIP study was 28% and 0% in Life registry. Now, what's also important, the median EVAR readmission cost varies from previous publications between $17,700 to $23,600, depending on what kind of complication occurs. So what we can see and we can say that Life readmission rate is 5 times less common than contemporary EVAR reports. We have also looked from the Life registry comparison of the peri-operative cost with so-called fast track versus standard EVAR. And what we can see here, that percutaneous access and repair with conscious sedation and local anesthesia can reduce the cost of the procedure for approximately $4,000 as seen here. We also carried on with support from Abbott Vascular, using IBM Watson Health on percutaneous femoral artery repair with ProGlide versus surgical femoral artery repair, not only for EVAR but also for TAVR and TVAR. And we longitudinally matched cohorts of approximately 55 million US patients between 2012 and 2016. When we look at the 30-day ProGlide, patients had 79% less likelihood to require blood transfusion during or after the procedure, and 55% less likelihood to have a hemorrhage, as well as 43% less likelihood to have an infection after the procedure, and the cost savings across the board were $14,687 for patients that had the use of ProGlide for percutaneous femoral artery access and repair. Now this was published, as you can see here, in a peer-reviewed journal. So there is no doubt that large bore closure devices benefited tremendously our patients as well as the physicians that were performing procedures and also the hospitals. Here we can see that ProStar and ProGlide are approved devices for pre-close technique, and MANTA is the latest one that has been approved abroad and also in United States for large bore closure. MANTA is truly a dedicated large bore closure device for femoral artery access and repair. On the bottom, there are two devices, CrossSeal and PercuSeal, that are still not being approved for clinical use in the United States, but CrossSeal is approved for clinical use in Europe. PercuSeal has undergone a clinical trial in the United States, but is not approved yet at the present time. It's important to mention that from the CrossSeal device study in the United States, the technical success for successful closure of femoral artery access was 94%. Now I would like to mention a few things about MANTA that is very commonly used nowadays for EVAR, TVAR, and TAVR, particularly in the United States but also abroad. This device achieves hemostasis by sandwiching arteriotomy with polylactic co-glycolic acid intraarterial toggle and extravascular bovine collagen plug that is sutured in place over polyester suture with a stainless steel lock. It's over the wire design, and there are two devices, 14 French MANTA and 18 French MANTA. It's important that 14 French MANTA can close this access site all the way up to 18 French, which is probably the only device that's needed for a great majority of large bore closure procedures. Here we can see the steps involving using MANTA for percutaneous femoral artery access and repair. It's important that we routinely use micropuncture kit and ultrasound guidance to gain access. Here we can measure the distance from the arterial entry point to the skin, similar like in angioseal device, and then we can use a proprietary introductory sheath as shown here to introduce MANTA and add a MANTA closure component to it. The wire stays in there as shown here, and the device is then introduced and locked into position with a proprietary sheath, as we can see here. We pull the device to a desired length, and then we release the toggle, as you see, by pulling the lever up, and at that point of time we can advance this pusher device to actually advance the collagen plug and the stainless steel lock in a fixed position right over the artery to achieve hemostasis, as we can see here, without any significant bleeding, even in a patient that is fully anticoagulated. We have here several publications related to Manto devices. We can see here from the US pivotal trial, the time to hemostasis was very short, less than 1 minute in great majority of patients, and the technical success was close to 98%, with a low incidence of either major or minor VARC criteria complications. And subsequently, we have additional publications by us and co-workers that showed that the success rate is high in across the board experience worldwide, with vascular complication occurring in 9.1%, which includes both major and minor vascular complications. So now it's important to mention that percutaneous femoral artery repair and a fast-track approach is not only used for EVAR but also for many other large bore access devices such as TEVAR and TAVR on routine basis by us and other interventionalists and surgeons. Here's an example of endovascular repair of the ascending thoracic aortic aneurysm, where the pseudoaneurysm shown on the left-hand side and endovascular repair with commercially available stent graft on the right-hand side. This was achieved by using RV pacing, similarly like during a TAVR procedure with accurate placement of the stent graft. Here's another patient with similar ascending aortic pseudoaneurysm before and after endovascular repair with another type of stent graft with a complete exclusion of the pseudoaneurysm, and then we can see at 1 year follow-up on a CT, excellent result and no evidence of endoleak. So we can say, in summary, that percutaneous large bore femoral artery access and repair provides benefits to the whole healthcare delivery spectrum. It benefits patients, it benefits physicians, and it benefits hospitals. The patient benefit include minimally invasive procedure. We can avoid general anesthesia complications. There is less blood loss. There are fewer growing complications, less pain, and quicker recovery time and return to normal lifestyle. There are also several physician benefits. It's a quicker procedure, no anesthesia delay. The patients are more satisfied, and we can improve the efficiency. There are also numerous hospital benefits. Number one, patient satisfaction is greater, lower infection rates, and therefore shorter hospital stay and need for additional procedures and treatments. The cost is significantly lower. There is less need for blood transfusion and improved efficiency. So in conclusion, there is ample evidence from multiple trials that percutaneous femoral artery repair for EVAR, TAVR, and TEVAR offers significant patient benefits and cost-saving measures in comparison to surgical access and repair and the use of general anesthesia. In the next decade, we will see an increasing use of large bore vascular closure devices due to popularity and benefits of percutaneous approach to EVAR, TAVR, and TEVAR. Thank you very much for your attention. My name is Vladimir Krejzer.
Okay. We really thank Dr. Krejzer for this fantastic presentation and for a topic that he's absolutely familiar. And if we have some comments, probably we have 2-3 minutes for discussion because we are over time already. Questions? Okay, if no further, I would like to ask Professor Velchev to join us here in the moderator panel, and we are starting. We are starting with the next small session. It's regarding dialysis access management. So again, access.
Yes, but it's a little bit different. So we are going to an orphan disease field in the endovascular field. So we'll start from the scratch, and we devoted this session to the people which are not so well acquainted with the problem. And we started with the echo assessment of the failed AV fistula, and I would ask our first speaker, Dr. Zlatanov, to join us, please. Here, because after the end of this session, we want all you to know how to assess and what to do and where to refer this patient, because access is life for these guys, it's not just cost saving. Dr. Zlatanov, please, it's your floor.
No.
Thank you, Professor Velchev. Thank you, Professor. Thank you, Professor Nikov. Vascular access and its subsequent complications seriously increase morbidity, hospital stay, and costs in hemodialysis patients. The percentage of thrombocyzed AV fistulas in the last 3 decades has increased because patients are older and often multiple previous vascular accesses. More diabetics are operated, and patients with more severe arterial atherosclerotic changes. Poorly selected preoperative artery and vein are the most common cause of early thrombosis of the high rate of inoperable AV fistulas. Challenges of vascular access after its construction. Problem with vascular access after its construction leads to its dysfunction, inadequate dialysis, hospitalization, even premature death. After its loss, another vascular access had to be constructed, and new surgical intervention and a period of recovery after it is necessary for the patient. It disrupts the patient's usual way of life and lowers his quality of life. And there are only about a dozen areas in the human body that can be used for vascular access construction. Each subsequent operation reduces the possibility of next access. Although rare, patients die because no vascular access can be constructed. Search for fistula dysfunction, diagnostic tests. Fistula follow-up is preferred by measurement of internally accessible blood flow, duplex Doppler, or transonic. We prefer duplex Doppler sonography. Measurement of static venous pressure, duplex Doppler scan, follow-up of fistula by physical examination is quite natural and also acceptable. Findings in well-functioning AV fistula. Regarding the inflow artery, monophasic spectral curve is a normal, large diastolic component. Regarding the anastomosis, perivascular tissue vibrate, hardly turbulent long-range spectral curve. Regarding the draining vein, pulsatile spectral curve, arterialization of the vein, blood volume through the AV fistula must be more than 500 milliliters per minute. Dilated inflow artery and outflow vein after several years of usage. Measurement of the blood volume in the AV fistula. This measurement of the blood volume in the AV fistula is a unique technical situation. By constructing an AV fistula, blood flow of the upper extremity with vascular access conduit increases 10 to 20 times. The researcher in this situation is most often looking for the presence or absence of the blood flow, an approximate estimate, rather than its exact measurement. A 5 to 10% error in blood flow estimation is acceptable, measuring the blood flow 3 to 5 times and averaging it is a way even more precise calculation to have a flow. Results obtained with duplex Doppler shows good correlation with other commonly accepted methods. Blood volume is calculated with this formula, cross-section of the conduit multiplied by the average velocity multiplied by 60. Estimation of blood flow. You have certain values here about normal values in antebrachial AV fistula, brachial AV fistula, matured AV fistula. Fistula with high probability of occlusion is when the blood flow is below 300 milliliters per minute, or if we use prosthesis, it is below 650 milliliters per minute. If there is a heart failure with high preload, with adults 3,000 milliliters per minute, and with children 700 milliliters per minute. This is the rule of 6, which we use when we construct and determine how to create an AV fistula. 6 centimeters segment for and more for cannulation, 6 weeks and more after the operation for maturation, blood volume through the fistula more than 600 milliliters, diameter more than 6 millimeters, and the depth under the skin surface no more than 6 millimeters. This is an example of well-matured, good diameter in depth AV fistula. Drainage vein cross-section 6 milliliters, 4.8 millimeters under the skin surface. This is brachiobasilic AV fistula with diameter 7.9 millimeters, blood volume more than 2,000 milliliters per minute. A large accessory vein located close to the anastomosis, and it prevents fistula's maturation. Immature fistula with small diameter and deep draining vein. Also, one example of immature low blood radiocephalic AV fistula with low blood flow. Unsuccessful failed fistulas, although the vascular access recommendations of recent guidelines suggest that the native AV fistula is the best vascular access to perform hemodialysis, many researchers have found a very high rate of unsuccessful failed AV fistulas, range from 29 to 53%. Failed AV fistula is defined as an AV fistula that soon after the construction is thrombosis or has not maturated, and in this way it does not allow proper hemodialysis through it. These are some of the reasons for such failure: ability of the heart to increase the stroke volume, inflow artery, the quality of it, surgical technique, construction via anastomosis, vascular access configuration, development of fixed anastomotic stenosis, stenosis of the outflow conduit, circulatory factors also can contribute to its failure. Fistulography and Doppler sonography is performed to clarify the location and degree of the narrowing. High-grade stenosis of the anastomosis requires urgent surgical correction. Indication for reoperation is stenosis more than 50%. Treatment procedures with priority are percutaneous angioplasty and stenting. Surgical correction of the stenosis is indicated after its recurrence or after 2 PTA within 3 months. Stenosis 3 centimeters from the anastomosis developed thanks to hip hyperplasia. How to measure the reduction degree of AV fistula woman? This is the formula: the difference between unchanged and narrowed woman, divided by unchanged woman, multiplied by 100. Duplex Doppler criteria for significant stenosis. This is the pronounced aliasing of the area of stenosis. The example is the entrance of velum basilica into vena brachialis. You can see well the aliasing. Criteria for significance more than 50% stenosis. Direct criteria: inflow artery, PSV ratio more than 2, anastomosis PSV ratio more than 3, and peak systolic velocity more than 400 centimeters per second, drainage vein with PSV ratio more than 3. There are also indirect criteria about blood volume less than 250 milliliters per minute, higher resistance index more than 0.7, and distal slow systolic rise. Significant stenosis of the anastomosis of the area of radiocephalic AV fistula, PSV ratio 3.4. Proximal venous stenosis, vena cephalica. This is the stenosis is located in the middle third of the arm. Why I think of the stenosis? Peak systolic velocity 610 centimeters per second. Distal venous stenosis. Marked why I think of the area of the stenosis, velocity 340 centimeters per second. Stenosis of the anastomosis between the vascular prothesis and the vein. Also peak systolic velocity 400 centimeters per second. Anti-Wissing. Few diagnosis of significant stenosis. The problem here is large inflow blood flow and large outflow blood flow. Brachiocephalic occlusion, resistance index 1, and thrombosis of the draining vein. Partial thrombosis and complete thrombosis of the draining vein. Fistula aneurysms is another complication developed after long-term use of the fistula. A well-functioning AV fistula, there are no thrombotic matters in the lumen. The underlying skin is intact. Intervention is rarely indicated for thrombotic substances. The underlying skin is severely altered. Constant or rapid enlargement of the aneurysm, obstructive kinking. And operative procedures are proximal venous arteriovenous anastomosis with arterialized vein, interposition of vascular prothesis, or new fistula. Diffuse aneurysmal dilatation, secondary as a result of degeneration of vessel wall or distal stenosis. True venous aneurysm, this is diffuse aneurysmal dilatation. To reduce such incidence, this complication, dialysis personnel should be cannulated the excess at each dialysis on rotational basis. Pseudoaneurysm, the incidence is at 2 to 10% during the entire operational period of vascular access. They are less common in native AV fistulas. Duplex Doppler findings, in and yang, outside, inside phenomenon, cover Doppler, pulse Doppler, to and fro. The presence of perianeurysmal fluid collection most often suggests an infection. Localization of these pseudoaneurysms in the area of cannulation. We need to observe them if they are small and stable, and surgery if they grow rapidly. Sometimes they appear in the anastomotic area, and they always require surgical treatment. Infection is the most common reason for the surgery. Brachiocephalic AV fistula 2 months after construction. Pseudoaneurysm. In and yang, inside-outside phenomenon. Covered. Pulse wave Doppler to and fro. Radial artery pseudoaneurysm. The perivascular space has a pulsatile bidirectional blood flow, typical in and yang phenomenon, and complete thrombosis of the pseudoaneurysm. Hematoma of the puncture area, this is another complication. Steele syndrome, blood flow from the ulnar artery passing through the palmar arc contributes to inflow increase through the AV fistula. Retrograde blood flow through the distal radial artery appears. Steele syndrome through the radial artery. AV fistula is fed by the proximal radial artery. In red, antegrade blood flow. The AV fistula is also supplied via the distal radial artery. In blue, retrograde blood flow. Digital ischemia caused by embolization from thrombosed AV fistula. Digital ischemia of all fingers of the left hand. And the example is a partially thrombosed radiocephalic AV fistula. Vascular access monitoring. To prevent thrombosis of the vascular access for hemodialysis, it must be continuously monitored, which includes persistent search for symptoms of arteriovenous protesis or fistula stenosis. Dialysis center should have a specific program for vascular monitoring and vascular access observation for early detection of problems in it. When indication of significant stenosis is detected, the patient should be promptly referred to for endovascular or surgical intervention. Patients on hemodialysis should be taught to self-monitor their vascular access. And of course, it is in this interdisciplinary team. Thank you for your attention.
It was very informative, and I think that if somebody is...
Готина свободна дискусия, показване на клинични случаи, горе-долу това. Ще бъде много приятна обстановка с съмишленици.
Okay, we continue in English, but my question would be, because you saw a lot of flow measurements, do we have some idea if we measure pressure, what is the normal gradient through the fistula? Is it such thing as a normal gradient, or it's up to the flow? I mean, if you measure pressure on the venous side, do we have some idea what the normal pressure on the venous side should be?
No.
No. That's the problem, that sometimes when you dilate, you need to have an endpoint, when to stop, because these lesions are very tough and undilatable. And sometimes we try to measure the gradient to the stenosis, but in this situation, it's not helpful, I think. Okay, thank you so much. Okay, sorry, we have a question.
I have a question. I'm interventional radiologist, which means this topic is a bit strange for me. I'm just curious. I would like to know how many years can you keep this fistula open, and approximately?
Our fistula, we have certain fistulas actively cannulated for hemodialysis about 10 years. And
10
more.
years?
Yes.
Okay, thank you very much.
Welcome.
Okay,
And
thank you.
More of that.
Thank you. We are moving to some more advanced imaging for central dialysis access. Thank you once again. Dr. Chupetlovska, please. The floor is yours.
Hello, everyone. Thank you to the organizers for the invitation. I'm a diagnostic radiologist. Do we have any diagnostic radiologists in the audience? Okay, you don't count. So I will be talking about, of course, being diagnostic radiologist, I will be talking about the non-invasive assessment of the failed central dialysis catheter. And I wanted to start with this quote, and I think our job as a diagnostic radiologist is to determine where the issue is, so determine the direction of the wind, and then it's your job to adjust the sails, which is point you to where the issue is. So I will start with a very quick introduction and definition, and then I will do a small diversion about which method should we choose, and the use of contrast media in the patients with impaired renal function. And then I will not be talking about the prevention and treatment, because this is your job. So as you all know, the number of patients who require dialysis is constantly rising. This is due to the obesity epidemic, the increased incidence of heart disease and diabetes. And in these patients, the dysfunction of the vascular access is a major cause of morbidity. So of course, in an ideal world, all patients will be having an AV fistula. But of course, there are some cases in which we might want to use central venous catheter. It is relatively easy to apply. It can be used very fast, so there is no need for maturation, as there is with the fistula. and sometimes it can be associated with lower costs. And of course, it might actually be a reasonable choice in some patients. For example, if we have a patient who has a lot of comorbidities, a patient who's very elderly, this patient might not live long enough to have the survival advantages of the fistula. And in some patients where we've already had multiple cases of thrombosis of several fistulas and grafts, sometimes we might just not have any more suitable vessels, so we need to use a central venous catheter. So you've all seen the first definition. As a diagnostic radiologist, I prefer the second one. We just care that there's some issue with the access. That's all we need to know. We don't do dialysis, so just tell us that there's inability to do adequate dialysis in this patient, and it's our job to evaluate the access. So of course, there is early catheter dysfunction. It's usually due to some mechanical issues, and late catheter dysfunction, and a lot of different complications which might develop on a timeline. Some of them very early, some of them require some time. But before we go to the complications, there is an important question that we need to ask ourselves as diagnostic radiologists. Of course, we always want to do a CT scan with contrast or an MRI scan with contrast, but we worry a lot when we have to do it in a patient with impaired renal function. And I would point you to this guideline. This was published 2020. This was done by a Japanese team. You can read the whole document by yourselves, but I'm just going to show and highlight a couple of the highlights of this document. So of course, some of the things make a lot of sense. They're just intuitive. Of course, if you have a patient with chronic kidney disease, they do have a higher risk of developing contrast-induced nephropathy. If you have a patient who's elderly, if you have a patient who has diabetes, all of these are, of course, risk factors. It's interesting that the solitary kidney, the evidence is unclear. We all worry a lot when the patient has a solitary kidney, but maybe it doesn't make a lot of sense. They don't appear to be at a higher risk. And when it comes to ISO and low osmolar contrast media, also doesn't make a difference. When it comes to intra-arterial versus intravenous administration, intra-arterial appears to carry higher risk, but this might also be due to the group of patients that require intravenous administration and their underlying diseases. And another interesting point is that the volume of the contrast media is important. So the recommendation is to use the minimum necessary volume. So of course, we're not going to make a compromise with the diagnostic quality of the study, but use as much contrast as necessary and no more. And when it comes to prevention, I'm not going to go into pharmacology, but I just want to point you to 2 points. So the physiological saline hydration seems to work well in reducing the risk, whereas oral water intake doesn't decrease the risk. So they recommend intravenous hydration or other established preventative measures, and we shouldn't rely on oral water intake, which is something that we tell every day our patients to drink more water before and after the study. This might just be useless. And most importantly, when it comes to blood purification therapy, they do not recommend doing hemodialysis immediately after contrast administration. If the patient is scheduled to have hemodialysis anyway, great, but there's no need to schedule hemodialysis after doing a contrast enhanced study. This doesn't seem to decrease the risk anyway. So keep in mind that the thing that we worry the most about is damaging the kidney function of this patient with the contrast. If he doesn't have any remaining kidney function and he's on chronic dialysis anyway, we don't care. So just do the contrast study. Don't worry too much about it. It's a different situation if you have a patient with acute kidney injury and you think that they might recover some of their kidney function. Of course, this is different. But in a patient who doesn't have any remaining kidney function anyway and is on dialysis, there's nothing for you to damage. So don't worry too much. We can worry about, of course, the increased volume and the increased osmotic pressure, but we don't put that much fluid in the patient, so don't worry too much about this anyway. And if we have a high-risk patient with a very low GFR, who's also has advanced stage, diabetes, hypertension, and so on, we should ask ourselves, is there another study that we can perform that could be more useful? And if no, then just go with it. You can hold diuretics, hold nephrotoxic agents. You can do some isotonic saline if the patient doesn't have fluid overload, and then use the lowest necessary dose. And when it comes to MRI, the thing that we worry the most when using contrast is the nephrogenic systemic fibrosis. This is a nasty disease. It's very rare, but it only occurs in patients who are on chemodialysis or have very impaired renal function and have had an exam with gadolinium-based contrast agents. But then keep in mind that we are now using mostly contrast agents from group 2. You can see the names on this slide. So this group of contrast agents, gadolinium-based contrast agents, are very, very safe. You can see even in patients with stage 4 and stage 5 chronic kidney disease, the chance of them developing nephrogenic systemic fibrosis is less than 1%. There's very few questionable cases reported, if any at all. So we shouldn't worry, and this is the recommendation from the American College of Radiology. You can see the risk of NSF is very, very extremely low, and they do say that the harms of delaying or withholding contrast for patients when it's clinically indicated, the risk to not do the exam outweighs the risk of NSF, regardless of the status of the patient, regardless if they're on dialysis or not. This is not something that we do regularly for patients to evaluate the central venous access, but it's useful in other cases if you have patients with malignant diseases, brain tumors, and so on. Do not withhold the contrast. Do not worry about NSF. Just use contrast from group 2, and you should be safe. As in any other case, we weigh the benefit, we weigh the risk, and we decide what's best for our patients. So I'm just going to very quickly go just through the most common complications. And a failed puncture of an arterial puncture, there are some risk factors if the patient is obese, if they had prior irradiation or some kind of operation to the region, and of course if we have a less experienced radiologist. And the rate of failed puncture appears to be higher if we don't use ultrasound, and is higher for the internal jugular vein than it is for the subclavian vein. And keep in mind some of this may be asymptomatic. When it comes to hematoma, again, the risk increases with multiple attempts in patients with coagulopathies. If they have any kind of variant anatomy, the risk is higher, of course. And the pleural space and the mediastinum are spaces where this hematoma may also occur. And these collections in patients who are immunocompromised could also be a risk for infection. This is a case from our practice of a patient who had a failed puncture when they tried to insert the catheter, had a huge hematoma, but in this case, the development was really good for the patient. This is just a day later, and the hematoma was significantly reduced. This patient had a full recovery, unlike the next one, who, again, a huge hematoma after failed puncture on the right side, then he had a successful puncture on the left. The hematoma was increasing in time, compressing the airways. The hematoma was also extending to the mediastinum. So this patient was intubated, and we decided to have another exam using contrast media, even though he had impaired renal function, because in this case we thought it was vital. We did see some leakage from the carotid artery, but the patient unfortunately passed away before any treatment was done. So, of course, we might also get a pseudoaneurysm. This is a case of a pseudoaneurysm of the femoral artery. And another very similar case, you can also see the 3D reconstructions. Another case of a pseudoaneurysm also seen on ultrasound. This is a pseudoaneurysm of the right subclavian artery. And another rare complication with pseudoaneurysm of the internal mammillary artery in this patient. And of course, there might be incorrect catheter position, rarely in the wrong vessel. Usually we might have a wrong position of the tip. and this might very easily be determined by X-ray. So no need for contrast or CT scan in these patients. So these are two cases where the tip is a little bit higher than you would like. For a normal central venous catheter, we're fine. If we want to do a dialysis, in these cases, we might prefer to have the tip in the ventricle, so to have a better flow. So these catheters are placed better. And this is another case of well-placed catheter with the tip in the right ventricle, and with a femoral catheter, you might want to have the tip in the inferior vena cava. This is a case of placement. This is a very rare scenario where the patient has anomalous communication. He has a left upper lobe vein, which is draining in a brachiocephalic vein. So the tip of the catheter is actually in this anomalous communication, which is rare. Another similar case, maybe a bit more visible, this catheter is not in the mediastinum or in the bronchi, as some radiologists might think. It is in an anomalous vessel. And another very rare complication of a misplaced catheter, the tip of the catheter is in the inferior vena cava, causing Budd-Chiari syndrome in this patient due to the occlusion of the inferior vena cava. And a very rare but potentially life-threatening complication is pneumothorax. This is quite rare, and usually you just diagnose it clinically, just using your stethoscope or just by looking at the patient. But if they get to the X-ray, it's not hard for us to see it. Other rare complications could be air embolism, nerve injuries, either directly when placing the catheter or afterwards due to hematoma or fibrosis, and cardiac arrhythmia caused by the irritation of the right atrial wall by the catheter tip. This is another rare complication where there was breakage of the catheter and a part of it remained in the heart. And keep in mind that these complications depend on the access that you choose. Of course, retroperitoneal hemorrhage, we're going to worry about it when we have femoral access, whereas subclavian or internal jugular could cause pneumothorax. For example, air embolus is more common in femoral or internal jugular access, and so on. And the late complication would be stenosis and thrombosis. They're relatively common. They increase with the length of catheterization. They might also be asymptomatic if they're not so significant. And the mechanisms which lead to the induction of venous thrombosis or stenosis are just the Virchow triad that you all know: the stasis, the endothelial injury, and the hypercoagulability state. Usually we see isolated swelling of the face or extremity with dilated veins representing collaterals. And the risk of thrombosis increases if we have a hypercoagulative state, including in patients with renal failure, if we have a catheter with larger lumen on the left side, with femoral access, and with multiple insertion attempts. This is a case where we can see thrombosis in the superior vena cava. Of course, we need contrast to evaluate the thrombosis. Don't worry too much about it. And another case of thrombosis in the superior vena cava with another complication, which is pulmonary embolism. And unfortunately, sometimes even after removing the catheter, we still, not all our problems are solved. This is a case where some venous fibrin sheet remained after the catheter removal, and it was cause of bacteremia in this patient. And another case when the catheter, after the catheter was removed, we still had some thrombus in the superior vena cava and some PE in this patient. So in conclusion, it is our job to choose the best methods to diagnose our patient, and as a diagnostic radiologist, we should be familiar with all the complications as to avoid unnecessary delays. And we are all part of a team. We should work together to determine the best treatment and the best course for our patients. Thank you.
I like that the diagnostic radiologist is the brain and the intervention radiologist is the neck. I like it a lot. Thank you so much. It was very informative and nice speech. If you have any question from the floor, it was important just to know that please don't hesitate to order the right diagnostic study if you need it, because otherwise, if you don't know what happens with your patient, you cannot help him.
Yeah.
So even with MR and with gadolinium, they think the message is clear, it's still safe to order it.
Yes.
Because if you have a central venous problem, usually echo is not helping. We need something more. Thank you so much. And now we are moving slightly to the field of intervention, and I would ask Dr. Pavlov to present some interventions on the failed AV fistula and the vascular.
Hello, everyone. My name is Pavel Nikov. I'm from Alexandrovskoye Hospital. I'll show you, my presentation will be very short, but I'll show you two cases. So the first case is a 56-year-old male with end-stage kidney disease. 2019 was performed the AV fistula, and 1 year later was failed. From the echo, our echographist sees a critical stenosis of the arterial part of the fistula with maximum speed from 3.5 meters per second. So you can see here, it's from the femoral approach. Can you play it one more time, please? You can see here, it's from femoral approach the diagnostic, and there is yes, thank you. There is a stenosis on the arterial side, just here, and this stenosis looks not so good, not so big, but you see after a couple of minutes it's very important. So, because of the not enough length of the catheters, we made the procedure with brachial approach, with V18 through the thrombosis in the venous part, so a pre-dilatation first in the venous part, and then we start with the dilatation of the arterial part, sorry. Now we have some flow, and it could be better, of course. First we made with bigger balloon, then with longer balloon. Here these are some pictures of the dilatation of the arterial part of the stenosis. So now you can see how the balloon is expanded, and still this stenosis stays the same. So we took a high pressure balloon, and after drug-eluting balloon expansion, this is the final result. And the patient could have his dialysis through the AV fistula on the next day. By this patient, we left him on dual antiplatelet therapy. The second case is a 54-year-old male, of course, with end-stage disease with diabetes mellitus and hypertensive nephropathy. Fistula surgery was performed 5 years earlier, and then 5 years later, of course, he came to us with the same problem. Here you can see first the thrombosis in the venous part, and then there's also stenosis in the anastomosis here. So the same procedure. This was performed with the femoral approach. We have the patient was not so high, so with white cut with long wire, sample 300 centimeter with similar balloons, a couple of dilatations. this is the result after the dilatation just in the venous part. So you can see something is flowing, but it's not enough, of course. Oops, sorry. Yes, this is after. This is the dilatation with the balloon of the anastomosis. It's a normal balloon. It's not drug-eluting balloon, and this is the result after. Actually, this is the final result. The patient could also have his dialysis on the next day. Our experience is not so big. We have 34 patients for 6 years with a success rate from 64%. And my key message is, it's not for you, it's for the patient, of course, you know this, but sooner the better. When he came a week later, or even after 2 weeks or something, the successful rate is not so big, and that's why we don't have 100% success. Thank you for the attention.
Dr. Nicole, thank you very much. I think I have a few questions for you. Sorry, please stay. The main question for me is, how do you plan your access? You always start from the femoral and then you decide what to do after you see diagnostics?
Yes, always from the femoral.
Do you have any complication from antegrade brachial puncture? Do you see any?
Yes, I think 2 times the band was not made properly, and then we have a hematome. But it's not critical or something.
Because I think antegrade brachial is something you do almost exclusively if you want to intervene on the IV fistula. Otherwise, you don't have any.
Just for the fistula.
Okay. And what kind of anticoagulation are you using during the procedure? Just standard heparin, something else?
Yeah, just the heparin. And the patient was on the dual antiplatelet therapy, 600 clopidogrel and 300 aspirin, 6 to 8 hours before the procedure. He was loaded with, on the dual.
My last questions, do you have any experience with stent graft inside the fistula, or you keep ballooning?
Just balloon.
Okay, thank you.
I have a question too. Where do you use the drug-coated balloons? Only at the site of the anastomosis or the whole vein?
Just the side of the anastomosis, because the venous part is, the woman is bigger, so I don't think that will help. We left some patients on heparin for 48 hours, for instance, just to make the flow better. So,
Thank you.
So we have a better chance that we have successful dialysis.
Okay, thank you.
Yep, thank you.
Thank you.
Okay, we keep on this track, and the next presentation will be about endovascular interventions for failed central dialysis access from Dr. Stoyanov. So we are moving slowly from peripheral to the heart. Please, Stoyanov.
Good afternoon, dear colleagues, dear chairs. It's a privilege to be here and to speak in front of you today. I don't have my presentation. Thank you. My task for today is to speak about the endovascular intervention for the failed dialysis catheters and dialysis successes. In international guidelines, it's recommended to use the strategy fistula first. But that's why this is because we have huge data that the usage of fistula is really better for the patients, and usage of central venous catheters is associated with threefold increase of mortality rate. But we have data that showed that in the last 3 decades, the usage of temporary and permanent catheters is increasing over the time. And that's why we have plenty of patients with failed dialysis successes. And as already mentioned, Dr. Chopetlowska mentioned what does it mean, the dialysis catheter dysfunction. This is direct from the guidelines for the vascular access. And as she said, probably the better definition is when we have a patient with catheter that doesn't work. But the official definition is when we have a patient with catheter that failed to attain a sufficient extracorporeal blood flow, and blood flow is less than 300 milliliters per minute. As she said, we can separate the dialysis catheter dysfunction to early dysfunction and late dysfunction. For the early dysfunction, usually is result of the mechanical issues, and we can underline some of the issues as a malposition of the catheter, kinking, and some others as catheter issues, tip design, and coating of the catheter. Usually we can avoid such a complication, early complication, only if we use X-ray guidance during our procedures. This really simple rule, but extremely effective. About the malposition, you can have a wrong vessel, as you can see on the right part of the screen. Here the catheter is, the position is not correct. It's in the azygous vein. And we have a few patients with this kind of problem. The azygous vein is bigger in patient with occlusion of the superior vena cava. And if you don't use X-ray guidance, you can easily reach this vein and to have a failure of the catheter really soon. Incorrect tip position. If you sometimes we have a patient with the catheters in the another jugular vein, or the tip is in front of the vessel wall, the superior vena cava, or the another innomina vein wall, and we have really early dysfunction. But this can be avoided if we placed our wire under X-ray control and to reach our region, the region that is the best for the catheter and to provide good flow. About the late dysfunction, we usually in our cath lab have a patient with late dysfunction, and we should deal with their problems. The most common issue for late dysfunction is the thrombosis. We can say that we can have a patient with internal thrombosis or with external issues for formation of fibrin sheet or thrombus around the catheter, and our main cohort of the patient is a patient with the central venous stenosis. For the intrinsic intraluminal thrombosis, our colleagues from the nephrology department, they are really good when they have these issues, and they use thrombolysis for this kind of problem. When we have a fresh thrombus, this is extremely efficient, and they use urokinases or tenecteplases with bolus, and after that continuous intravenous infusion, and this is extremely useful and effective. Our job, daily, everyday job, is with a patient with fibrin sheet formed around the catheters and dysfunction because of the central vein stenosis. The fibrin sheet formations started almost immediately after the implantation, in the first 24 hours, and this is really important, and we can have the fibrin sheet formation and dysfunction in the first month after the implantation, and this is important. And this is really important reason for this function. And as you can see, about 50% of the cases for late dysfunction, the reason is the fibrin sheet formation. But what does it mean, the fibrin sheet? This is thrombus, endothelial cell, and collagen formation around the catheter. And in the different stages, you can find this sheet. And what's the problem with this sheet? We can easily inject through the catheter, but when you try to aspirate, the fibrin sheet develops something as a one-way stop valve. We cannot aspirate through the catheter, and this is the main problem here. How we deal with this kind of patient? Usually we can balloon it. On the screen you can see on the left side the 035 wire inserted through the dialysis catheter, and this is the fibrin sheet around the catheter. Usually we are inflating balloons to disrupt the fibrin sheet, and we are using the balloon catheters between 10 and 16 millimeters, and we are trying to keep the rule for really high pressure dilatation. But unfortunately, with this kind of technique, we don't gain a lot, because the patency of the catheters is about 1 to 6 months, and that's not a lot for this patient, because this is for their life. What we did in the past, we used the contralateral jugular vein to avoid to put the new dialysis catheter in the fibrin sheet. But now we changed the strategy, and we are using more and more ultrasound guidance when we puncture. Most of our patients are patients with catheter inserted with posterior puncture of the internal jugular vein. Here is showed how to perform this kind of puncture. And when we have a patient with fibrin sheet, we check with ultrasound the patency of the same jugular vein. We put the 035 wire into the catheter, perform this proper dilatation with balloon catheters, and after that, with the ultrasound, we puncture anteriorly the jugular vein and insert the dialysis catheter next to the fibrin sheet. And with this maneuver, with this kind of technique, we can have a longer patency of the dialysis access, and also we preserve the contralateral jugular vein for the next interventions. The other technique that we use is the stripping. This technique is extremely effective and useful in patients with fibrin sheet formatted around the catheter and without infection of the catheter. Usually we use 6 or 7 French 65 centimeter sheet from the femoral vein and gooseneck snare, interventional snare. We place the snare around the catheter and just strip the fibrin sheet. Usually the fibrin sheet is going to the pulmonary artery, but this is not a problem in general. We don't have a patient with compromised hemodynamic because of the occlusion of the pulmonary artery. As I said, the other part of our daily practice and our daily job is to fight against the central venous stenosis. There, the incidence of the central venous stenosis is quite high, and according to data that I found, we can see the central venous stenosis in temporary central catheters about 40% after the implantation of temporary catheters and 27% with permanent central catheters. They are more often when we use a subclavian vein access, and that's why the preferred access is the internal jugular vein. How we deal this problem? Usually we use plain balloon dilatation for this kind of patient, but as you can see on the screen, the patency of the catheter after that is not so impressive. About 30% at the 6th month and 25% the first year. We have data that if you use a really high pressure balloon dilatation, you can increase the patency up to 60% at the 6th month, but our results can be compromised with if we have immediate elastic recoil. In such cases, we need to implant a stent at the place. About the stents, we are using, not so often, but we are using bare metal stents, but mainly in cases with elastic recoil or for bailout. The patency of the bare metal stents is pretty much the same, not so impressive, about 50% at the first year, but we can have a really major complication during the implantation of the bare metal stents, and these complications are stent migration or rupture of the superior vena cava. About the stent grafts, they have excellent results, but their price is really high, and we should keep in mind that there is a really important bifurcation, the both innominal veins, and we should really plan our procedure where we want to implant the bare metal stents. In the conclusion, unfortunately, we see a lot of patients with permanent dialysis catheters. This can be explained with this, that it's really easy to put the catheter, to use it immediately. We don't need the maturation, as that it's not the case in a fistula. The patients prefer, more of the cases prefer the central dialysis catheters because they don't have a puncture of the skin, and we should know how to deal with this really often problem and to save the lives of our patients. And of course, our treatment as an endovascular specialist, endovascular treatment is the first line treatment for this kind of patients. Thank you.
Do you have some comments? I think our key message is that we have to stick to the one side and exhaust all the options, because sooner or later you will have the patient with exhausted access, and that means that there is no life for this guy, because dialysis have to be done. And even some of these patients end up in the cardiac surgery departments with the catheter implanted with the sternotomy straight in the right atrium, which is the really final step that we can have. Okay, thanks so much.
Thank you.
Thank you.
And the next presenter will be Dr. Alexandrov. He will be talking about superior vena cava syndrome in dialysis patient.
Hello, dear colleagues. I'm really proud that I can speak in this nice meeting. My presentation will be relatively short because, as I anticipated, most of the things that I should say were already said by the previous presenters. The etiology of the superior vena cava syndrome is mainly due to the malignant obstruction of the superior vena cava, with the lung cancer accounting for more than 80% of the cases. And of course, another cancers could be the reason. The most often benign reason for superior vena cava syndrome is catheter-induced thrombosis. There are a lot of classifications about the superior vena cava syndrome, anatomical, clinical, and risk classifications. And the anatomical classifications is mainly accounting for, is it a full thrombosis of the vein, or is it a high-grade stenosis, and of course the site of the occlusion or stenosis before or proximal or distal to the azygos vein, which accounts for the symptoms of the patient. The clinical presentation could be from asymptomatic to fatal. Of course, some of the cases could be very severe with cerebral and laryngeal edema and limited cardiac reserve, and sometimes could be life-threatening. As I said, the most often benign reason is catheter-induced thrombosis, and of course this is mostly the cases in hemodialysis port. The actual prevalence of the superior vena cava syndrome in hemodialysis is unknown, mainly because most of the times the syndrome is asymptomatic and is found with no symptoms. Of course, the pathophysiology of the thrombosis was already mentioned, mainly due to damage of the wall of the venous wall by the catheter, the high blood flow, and due to dialysis and the endothelial dysfunction. Of course, there are some risk factors that can promote thrombosis of the superior vena cava, longer and thicker lumen of the catheter, longer placement duration, differences in the blood flow, some catheter-related characteristics like a large caliber to vein ratio of the catheter. Some materials of the catheter are more risky than others. Trauma due to the vein puncture, not proper catheter position, and some patient-related characteristics like malignancy or previous thromboembolism. Of course, the endovascular treatment of the superior vena cava syndrome is a first-line treatment, and surgery is a second-line treatment when endovascular procedure is not possible. It has a high technical success rate, between 95 and 100%, and a low complication rate. The early and late complications of this procedure were already mentioned by Dr. Stoyanov. I'm not going to pay attention to this. I want to show you a clinical case from our practice. It's a 73-year-old female with a terminal stage chronic kidney disease on hemodialysis with a previous catheter, dialysis catheter, through the right jugular vein. She came with face, neck, and upper extremities edema, cyanosis, and you can see distended veins on the chest and abdomen. A CT scan was done in another hospital, so I cannot show you the images, but it showed occlusion of the right jugular vein, right at the outlet of the vein, and high-grade stenosis in the osteo proximal segment of the superior vena cava. Under ultrasound guidance, we puncture the jugular vein, very high. And we did recanalization with a status 30 wire and a Navicross. You can imagine how tough this occlusion was, and everyone that has hold on a status 30 in their hands knows that this wire can be extremely tricky in a vein. But we got lucky with no complications, and we managed to recanalize the jugular vein. Afterwards, we snared the wire and did externalization just to be sure we have enough support and just to be sure that we are not going to lose the wire anywhere. I don't have the picture, but we did, at the site of the occlusion, we did a balloon dilatation with 12 millimeter balloon with a very decent result at the outlet of the jugular vein. So we continued to treat the osteostenosis of the superior vena cava with a CP stent that was pre-mounted, crypted on a 20 millimeter balloon. The balloon was inflated, and you see that it's really, really tough stenosis. And the stent couldn't be completely opened, but when we moved the balloon distally and did a flare actually to oppose the stent, because the distal part, the proximal part of the stent is actually inside the right atrium, we had to do this flare just to be sure that the stent is really well opposed to the atrial wall. And we managed to achieve a pretty decent lumen at the site of the stenosis, which was 14 millimeters. And we decided to stop right there because it's pretty close to the atrium, this part, and giving higher pressure could lead to a rupture, tamponade of the stent, and we decided that the enemy of good is better, so we decided to stop there. And this is the final result with a very good flow to the right atrium, and this is the same patient after the procedure. She looks completely different person. So the endovascular treatment is the treatment of first choice. It has a high level of technical success, low percent of restenosis and reintervention, and a low percent of recurrent events. There are, of course, a few issues that I want to count. The first thing is that we don't want this to happen. We don't want the thrombosis to happen and to do this kind of procedures. So the best thing we can do is prevention. The most often used prevention is heparin solutions as a post-dialysis lock in the catheter port. There are some data, controversial and inconclusive, that early warfarin or vitamin K administration could lead to some benefit, of course at the cost of higher bleeding rates. And of course, after the first event of thrombosis, vitamin K is indicated in a dosage in a stepwise fashion, starting from lower INR between 1.5, and if recurrent events occur, the INR could be increased to 3.5 as in a mechanical mitral prothesis. As to my knowledge, there are no randomized trials that test NOACs or DOACs for the prevention of superior vena cava syndrome or thrombosis. This could be something that has to be investigated, because we know that NORCs are superior to warfarin in some clinical scenarios. Maybe there could be in this matter too. And of course, the other issue is that when we do the procedure, the endovascular procedure in the superior vena cava, if you want to achieve a very nice angiographic result, we should place a stent. But placing a stent in these patients that need dialysis access for a long time of period, and puncture of different veins, when placing a lot of stents, we could actually have a very nice angiographic result, very nice patency of the vein maybe, but we could make impossible to get another venous access for those patients. So my opinion is that we should, in those patients, the use of stents should be limited and very precise, not to be used in bifurcations and to be obstructive for another vein access. Thank you very much for your attention.
I think he raised a lot of issues with this presentation. Actually, the patient was dialyzed by the AV fistula, I guess. The patient that you just showed us. What was the access for dialysis?
No, another catheter from the femoral vein, the right femoral.
The femoral.
Yeah.
So we have a typical situation here, because the femoral catheter doesn't last long, usually.
That's true. Yeah.
So sooner or later, you will have to put a catheter through the stent. And then you will have the issue with sometimes very quick neointimal proliferation and occlusion of the stent. Do you think the surgery have something to offer in this situation?
I don't think so. I don't think so. But in this case, it was a CP stent graft. So if you put a dialysis catheter after that through there, you can always keep your opportunities for post-dilatation of this stent graft.
Stent graft is wise, I think, in this occasion.
It was a stent graft.
Yeah, I said stent, or it was a stent graft, a CP stent graft, yeah.
And what is the restenosis rate in your series of patients? Because we know
we don't have that much patients to be conclusive.
Because in our experience with CCSVI and also inferior and superior vena cava, we know that the venous stenosis are very resistant. It's not in fact plaque, it's wall resistance, and the fibrotic tissue there is so impossible to be dilated that in many times we need non-compliant peripheral balloon. So I know in Bulgaria they are not popular because of the price, but in fact, like in your case, that you have shown that the shoulders of the balloon are overexpanded, and the middle part is very difficult to be expanded. In this case, we need really a non-compliant balloon.
But are we going to achieve better patency or with full dilation?
Yes. No, I not criticize you. I'm
just
sharing that in such cases, like I think one of them is a true balloon. The true balloon, I think it's from Bart. It's a really non-compliant balloon, and this is the right choice in order not to damage.
We are using mainly Atlas from Bart when we do the iliac intervention. So it's the same,
Absolutely.
Atlas Gold, non-compliant balloon.
What I was thinking about surgery, that in this situation, you have two choices. You have to put a catheter through the stent, one situation, and this situation, maybe if you post-dilate it would be better.
Yeah.
And the other option would be some proximal prosthesis to recreate some AV fistula with the help of some prosthetic material, because otherwise you end up with the center dialysis catheter anyway.
There is a device, a new device, inside out, that comes out from the skin, but I don't...
Yeah, it's good, but it's good if you have to recanalize. In the case of the closed jugular, it's fine. You can fall down up, and then you puncture the skin, and you make your tract. But in this situation, you already recanalize the vessel, so it doesn't do the job. The truth is, these guys will end up sooner or later with some advanced surgery, I think.
Yeah. Unfortunately.
Okay. Thanks so much.
Thank you.
Thank you.
And now it's my pleasure to announce a lecture on a slightly different topic.
Yeah,
It's, how to
you mentioned we are moving to the heart, and now even more we are measuring to the arteries. So moving from from the veins to the arteries. I will speak about one of the biggest killer nowadays, cardiovascular disease and the dependence of cardiovascular disease by lipids. Nothing special to disclose regarding this. Sorry, 30 seconds. This is a wrong presentation, unfortunately. Okay, so, yeah, this is the right one. Regarding the cardiovascular mortality, I mentioned already this is the biggest killer nowadays. So it's true that there is some kind of plateau in some countries, like in US, but for all the rest of the world, there is increasing of the cardiovascular mortality. And this unmet need is definitely into the trials. It's related to the levels of LDL cholesterol and the LPA, lipoprotein A. So these are probably the two very important targets for treatment nowadays. In all the nomograms of the cardiovascular risk, the higher the cholesterol level is, both in women and men, the higher the cardiovascular mortality is. And this is very well shown in probably hundreds of trials showing there is a direct relationship, incremental relationship between the LDL levels and the cardiovascular mortality. In our local observational study in 1,900 patients in 5 hospitals in Bulgaria, among patients with acute cardiovascular syndrome, peripheral vascular, coronary vascular, or cerebrovascular, so all kinds of acute cardiovascular and cerebrovascular events between 2008 and 2019, using a special software for parametrization of non-parametric data. We have shown that in these hospitalized with acute cardiovascular event patients, the Dutch criteria for familial hypercholesterolemia, especially for the LDL level above 8, is 6.5. So it's a significant number of these patients there with a very high level of cholesterol. And unfortunately, in this population, most of them, 35%, they had a previous CV event. It means that the healthcare system, in fact, lost them from control. In case more than 1/3 of these patients, they have recurrent event. Regarding, unfortunately, it was a pity to observe that even the medication combined or single high dose of statin medication didn't change too much from the admission to the dehospitalization. And of course, this led to very bad clinical situation. And depending on the LDL level, in fact, the attainment of the goals, both American guidelines or European Union, the European guidelines are even stronger for patients with high cardiovascular risk, were not attained. So the majority, more than 90% of these patients with extremely high cardiovascular risk didn't attain the goal of 1.4, even 1.8. And why this is so important? It's clear, because into the trials, it was shown also the opposite, that reducing the LDL, there is a really reduction of the cardiovascular risk and cardiovascular mortality. I mentioned already that the European guidelines in patients with high risk are to attain 1.4 millimole per liter for the LDL cholesterol. The American guidelines are still a little more liberal, but we know that we are catching one the other in many situations. Probably they will also change the guideline. And what about the good treatment? The good treatment, of course, is in evolution. Since more than 10 years, the statin therapy, in high-intensity statin therapy, is the golden standard, class 1. In patients that are not achieving the target, ezetimibe, in fact, added to statin, is also with class 1, the combined treatment. And in this particular group with combined intervention, high-intensity statin therapy, with ezetimibe, and still the target are not reached, we have to add the PCSK9 inhibitor again with class 1 indication. And of course, this is extremely important because the percentage are showing that the lower, the better. In the case of lipids, the lower the better. Unfortunately, in many trials, it's shown that the discontinuation has a significant proportion. More than 50% of the patients are discontinuing their medication with statins for different reasons. In most of the patients we know very well, these are side effects like myalgia, like some nausea, vomiting, and so on. Some collateral effects that are not so infrequent. We know that of course, the companies say they are not dangerous. I had in my practice only one patient with a real rhabdomyolysis. So fortunately, he survived, but he was in a critical condition. Rhabdomyolysis is very rare, but collateral effects like myalgia are very often, probably 25% of these patients in high-intensity statin therapy, they have myalgia. And there are different reasons, but it's true. A significant part, at least 50% of the patients, they stop their statin therapy. And there are several trials that show us that stopping the statin therapy is not a good idea because the risk is very fast going up. In not more than 2 months, and the risk for cardiovascular events is going up because of reaching again the same level of LDL. So this is very important that this discontinuation is happening so often. So what to do next, more than PCSK9 inhibitors that are now in the daily practice? The Nobel Prize awardees, Andrew Fire and Craig Mello, in fact, they showed us another horizon. This is the so-called small interfering RNA. These are small RNA particles. The first one that is on the market is the so-called inclisiran. So the inclisiran is mimicking RNA molecule that is in fact interfering the activation of the DNA responsible for the protein of the PCSK9 protein. So in fact, it's not blocking already produced PCSK9, but interfering our liver to produce PCSK9. So it's just from the beginning. And the other, this is the so-called silencing. So these are the silencing RNA that make sleep the DNA that is producing the protein. So this is the mechanism. It's probably quite important to mention that it's not into the nucleus, but into the endosome, into the cytosol of the hepatocyte target. The target is the hepatocyte and not the circulation, Unlike the PCSK9 inhibitors, they are circulating in our blood. And the silencing small RNA particles, they are targeting only the hepatocyte, not at any other place, working their job on the level of the hepatocyte. So this is very important, and we see that these are the differences, in fact, between the PCSK9 inhibitors and the silencing small RNA particles. So because you see how low is the concentration of the inclisiran into the blood. And okay, this is the group of trials showing the value of this new treatment in different populations. Of course, population with high levels of LDL, more than 2.6, and in different clinical scenario. Familial hypercholesterolemia, heterozygote. Why heterozygote? Because the homozygote, they don't survive. So they don't reach the age to be included in a trial. So because of that, heterozygote patients with familial FH are included. Patients similar to our local registry, acute cardiovascular events, and patients with acute cardiovascular events plus risk equivalents like diabetes. So we know that diabetes mellitus is considered like a coronary artery disease. And the regime is very interesting. We know how we were happy about the PCSK9 injecting inhibitors every two weeks. The inclisiran regime is first day, third month, and after it, every 6 months. So only twice a year. Only twice a year, because the half-life of the small silencing RNA particles is very prolonged, and it's targeted directly into the liver. So it's not circulating in the blood, and because of that, it's not eliminated. And this allows this very prolonged regime of application. The inclusion criteria I mentioned already, not reached target of the LDL cholesterol. And of course, these are the key primary endpoints comparing to and this is on top of the golden standard, so statin, ezetimibe, and so on. So on top of this therapy, every single patient received all placebo or inclisiran. And these are the key points, the attainment of the change in the LDL cholesterol from baseline to day 510, and time-adjusted percentage change in the LDL cholesterol level from baseline after day 90, so the second period. And there are several key secondary endpoints, again, taking into account LDL cholesterol, but also the level of the PCSK9 circulating, ApoB, and non-HDL cholesterol, and of course, some adverse events related to the new medication. There were no any significant difference into the clinical characteristics. And what about the results? The results are impressive. Such results were not achieved by any medication to date regarding the LDL cholesterol. In all the three, you remember, the three different clinical groups, Orion 9, Orion 10, Orion 11, patients with familial cholesterolemia. You probably know the average life expectancy of FH patients, it's 44 years. So they die early. And it's so important to reduce in them the LDL cholesterol because this is the main killer. So, and also the patients with acute coronary or cerebrovascular syndrome, in all of them, the goal to reduce with more than 40% the level of the LDL cholesterol was reached. And in fact, the LDL cholesterol threshold to reduce the cholesterol below 1.8 millimole per liter was reached by almost 90% of the patients. That is absolutely unbelievable. And it independently on statin or not statin, on which statin, if the patient was obese or not, independently of these factors, this target was achieved by the inclisiran. And it's very important on, in fact, comparing the patients on statin treatment plus placebo and on statin plus inclisiran. And the aggregate analysis, you see how big is the difference of achievement of the goal that is so important for this group of patients of very, very high risk. And these are the secondary endpoints. You see that the PCSK9 level, the total cholesterol, the non-HDL cholesterol, ApoB, and the lipoprotein A, that is very important during the last several years. We pay very big attention to LPA. In all these laboratory factors are definitely with a very big decrease in the trial. And why is it's well tolerated? In fact, the discontinuation of the medication was less than 2%, because the risk, the collateral factors like arthralgia, urinary tract infection, diarrhea, pain, they are up to 5%. You see, between 3.2 and 5%. So it's not so pronounced like in other trials with statins, for example. And this goal was achieved independently on the renal function. We cannot mention many of medication that is independent on renal function. And in this case, it's independent because the target is only the liver, nothing else. And it was really impressive. And what about, we have mentioned already the discontinuation of treatment. In fact, in case we have 2 injectable applications per year, in fact, this is a treatment always on, because after putting the injection, the treatment is there for 6 months. And unlike the statins, we have 365 applications per year. For the PCSK9 inhibitors, we have 26 injection applications, and with the inclisiran, only 2 injections per year. And thank you very much for your attention.
Thank you. Thank you, Professor Petrov.
If you have questions, comments, new medication in your brains? Yes? Yeah, in fact, the Victorian program, this was the last slide, will give us much more clinical data. There are now a series of trials, ongoing trials, that will show in fact, the real life data. And of course, I think since the next year, there will be at least in some countries, the inclisiran will be included into the daily practice. Probably in Bulgaria, not so soon, but hopefully after the next year, so in 2025 probably, hopefully we are going to have the medication on site.
So, if there are no more questions, coffee break?
Going up. Okay. Again to the Venous. We are continuing. We have a coffee break, and after the coffee break, we continue with the venous pathology.
presentation is pelvic congestion syndrome. Dr. Volchev, the floor is yours.
Dear colleagues, dear chairman, thank you for the opportunity to share our experience with pelvic congestion syndrome. According to many vascular specialists all around the world, we can say that this is the most untreated, most underdiagnosed, most undertreated medical condition, and the average time to put down the diagnosis is around 4 years, which is much more comparable to some cerebral tumors and so on. So the classical explanation of this syndrome is commonly recognized as a persistence of pelvic pain for longer than 6 months in absence of other known pelvic pathology. But to be honest, we have several diseases that are connected with the pelvic congestion syndrome, and they are maternal syndrome, pelvic congestion syndrome, and nutcracker syndrome. And it is a complete mess. There's a complete nonsense of the nomenclature regarding the pelvic congestion, because we know that maternal may lead to edema and venous claudication. Furthermore, pelvic congestion may lead to chronic pelvic pain. And what about nutcracker? That can lead to left lung pain and hematuria. But also maternal may lead to chronic pelvic pain, and nutcracker can also cause chronic pelvic pain. And what about varicocele? We know nutcracker syndrome may cause varicocele, but we have also pelvic origin extrapelvic symptoms like vulvar varices and atypical varices on the lower extremities. That might be caused either by maternal or pelvic congestion or by nutcracker. So, to be perfectly honest, we are in this situation right now. We have so many conditions, so many symptoms, and this leads to inaccurate diagnosis, to poor treatment outcomes, and research limitations. So, I was happy enough to visit the World Congress of Phlebology a week ago, and the conclusion at the end of the pelvic congestion session is that we should no longer use the term pelvic congestion syndrome, and rather we should use the pelvic venous disorders. And to put into perspective, there's a new statement regarding pelvic venous disorders, that this is pelvic venous reflux plus hypertension with a dysfunction of the pelvic floor, with pooling of large venous blood volumes. I am emphasizing the words pelvic floor and pooling of large venous blood volumes, because often we discuss the topic, can we compare pelvic varices with lower extremity veins? Maybe yes, maybe no. As you can see on the first slide, there is the first in-human cadaver research regarding the valves inside the pelvic veins. And the authors concluded that there's a very low number of valves inside the pelvic veins into the internal iliac veins, and maybe the reason for this stagnant flow into the pelvis is not only the valvular insufficiency, but rather some genetic structural venous wall abnormalities and hormonal changes. So, when we see a patient with chronic venous disease, we always explain that there's some problem with his calf muscle pump, but we never explain our female patients that they have some dysfunction of the pelvic floor. And throughout Europe and USA, there are many special clinics where they encourage their female patients with this condition to perform some form of rehabilitation or exercises to strengthen the muscles in the pelvic floor, and by doing this we can avoid more than 50% of the operations we make only by doing these special exercises. There are many unknown things regarding pelvic congestion or pelvic diseases, and there are many leakage points in the pelvic veins. As you can see on the diagram, there is an obturator leaking point, inguinal, the gluteal leaking point, and the question is, can they be compared with the perforating veins on the lower extremity, because basically they do the same thing. They provide the high pressure from the pelvis to the varices, to the lower extremities. And as we still don't know what to do with the perforating veins, you can imagine that we have no statistics, no trials regarding the escape points. Should we treat them first? Should we treat them last? Should we treat them at all? So you see the incidence of pelvic congestion is up to 15% of women between the age of 20 to 50 years have varicose pelvic veins, and 60% of them experience symptoms. Over 10% of the gynecological referrals are for this condition, and over 30% of pelvic pain is caused by pelvic congestion, so it's very frequently observed. Regarding the clinical presentation, we should divide the body into 4 segments, and this is very important for the newest classification I'll show later. You see the first region. The first region includes the renal vein. So we have renal symptoms regarding left flank pain and hematuria. The second region is the gonadal and internal iliac veins. Of course, the symptoms connected with these are chronic pelvic pain, dyspareunia, and postcoital ache, which sometimes lasts for several days to several weeks. The last, regarding pelvic congestion, is the pelvic origin extrapelvic veins. People who are vascular specialists and are dealing with varicose veins, we often see this very unusual presentation of the varicose veins, and we are struggling to find out why these veins appear, because we see on the echo that the gross saphenous vein is fine, there's nothing wrong with the deep venous systems, and when we follow these atypical varicose veins, we see that they're coming from the pelvic region. So we should treat the pelvic first. Regarding the diagnostic testing, we are putting much emphasis on starting with the non-invasive testing like pelvic ultrasound, but there's still no strong evidence regarding whether we should go transabdominal, we should do a transvaginal or transperineal. According to the European guidelines, there is no strong evidence that we should perform transvaginal ultrasound, but most of the centers and the clinics throughout Europe and USA are using mostly transvaginal. And another advice to people who are involved in the diagnosis of this disease is that the examination should be performed when the patient is standing. Because there are many diagnoses like nutcracker syndrome, for example. When we examine our patient in a flat position, we see a nutcracker anatomy. But when we perform Valsalva maneuver, or when we make our patient to stand up and we perform another ultrasound examination, we see that the nutcracker is gone. So these patients simply have nutcracker anatomy, not a nutcracker syndrome. Once we have the clinical suspicion and we have the ultrasound suspicion, we go directly to CT venography because it is very easily accessible, relatively cheap, non-invasive. But to be honest, maybe MRI image is much better regarding pelvic veins. So far, venography, according to the more of the specialists in Europe, venography is the gold standard, and it gives us the opportunity to perform Valsalva maneuvers and to prove that there is a reflux in the gonadal veins. We shared a few things. Venography, there's one big misunderstanding regarding vein size. Usually, in most of the publications, whenever we see an ovarian vein larger than 5 or 6 millimeters, we consider that the vein has reflux. There are many researches proving that the size doesn't matter at all, and we should always perform venography with the Valsalva maneuver. There's a very wide differential diagnosis, but the most common causes that can mimic these conditions are chronic pelvic inflammatory disease, sacroiliac joint inflammation, and recurrent urinary tract infection. So basically, this is the latest classification regarding pelvic congestion syndrome. I had the great pleasure to meet Professor Meissner in a week ago. So the newest classification shares the symptoms, varices, and pathology classification of the pelvic venous disorders. So basically, of course, the body is divided into 4 parts, and the symptoms are ranging from S0 to S3. And again, this is true for varices and for pathology. So if we follow the latest classification regarding pelvic congestion syndrome and we follow all the instructions, for example, pelvic congestion syndrome with chronic pelvic pain due to bilateral ovarian reflux should be written down as follow. And it should be read backwards. Non-thrombotic reflux in both gonadal veins causing varices in the pelvis and pelvic symptoms. Of course, they have also created an application that can anyone download and put the symptoms so the diagnosis will appear. I know this instrument is very complex, but to be honest, pelvic venous disorders are complex. And it's also true that the same has been said for CIAP classification that we are currently using when we stage our patient with chronic venous disease. So far, there are many controversies regarding pelvic venous disorder. For example, does size really matter? As I mentioned previously, you see a sample that says that reflux in the gonadal veins is not directly proportional to the size of the vein. Another issue is that should we go transjugular or transfemoral? Should we use polydocanol or STS as a sclerosing agent? Should we perform tight packing of the coils or some loose deployment? Should we use sclerotherapy at all? How distant should we go? And we have no comparing analysis regarding should we put coils, should we put plugs or maybe onyx? And should we treat bilateral at the same time? So we had a clinical case, 41 years old female after 2 pregnancies who is complaining of constant pain and heaviness in the pelvic region. And she also had a postcoital pain which lasts for several days. She's 41 years old, no comorbidities, and venoactive drugs reduce the symptoms. She's been cured with venoactive drugs for several years, but her complaints are getting worse every day. So we performed thorough patient history, transabdominal ultrasound, CT venography, and we connected the dots. So we decided to perform venography plus the intervention itself. We performed a selective venography in the left gonadal vein, and as you can see, the size is very impressive. It's around 10 millimeters, which is much above the average. We placed the catheter down below and we performed another venography, which shows a very stagnant flow inside the pelvis. And you can see the contrast is even crossing the midline. And on the late images, we can see the internal iliac artery on the opposite side. So we decided to insert a simple Fogarty catheter, 5 French, because it has a very compliant balloon. And in this way, we can occlude the pelvic vein, and we decided to perform a foam sclerotherapy, injecting about 8 milliliters of foam, 3% at toxisclero. And if we can compare the previous picture, this is the picture before the sclerotherapy. And on the next slide, you can see the effect of sclerotherapy. There is much spasm, and you see the veins are really contracted. So we decided to implant the first coil. This is Nestor 12 millimeter pushable coils. After that, we retracted the Fogarty catheter and inserted another coil. This venography was performed to the femoral sheath to prove that this balloon occlusion doesn't allow any contrast to go further. So in this way, the foam we're injecting is staying down into the pelvic region and it's not propagating back into the renal vein. So in this way, we're reducing the complications. You see this is the implantation, very tight packing of the second coil. And here you can see the procedure of again injecting the foam, and you see we can follow the foam that displaces the contrast from the gonadal veins. This is the insertion of the last coil, and we perform venography from the renal vein to prove that there is no filling of the ovarian vein anymore. So this is the last picture that shows 3 coils and sandwich techniques. We put foam between the coils. So in conclusion, we can say that pelvic venous disorders are very common among our female population, our female patients, and they may lead to significant worsening of quality of life. And this is a meta-analysis that shows that technical success regarding this procedure is very high, reaching to 100%, and the clinical success rate, even in patients who are followed for more than 5 years, is above 90%. So treatment is technically feasible, offered great short and long-term results, and we should pay more attention to women with these complaints. Thank you for your attention.
Thank you very much for a very interesting presentation. There are some articles that suggest that pelvic embolization may lead to infertility women. Do you think that this procedure should be performed only women that are not expected anymore childbirth?
Thank you for your question. That's a very provocative one. I've also seen this article, but there are many new publications from 2020, 2021, where they followed patients for several years, and the largest sample I saw were 200 patients, female patients. So they examined the level of their follicle-stimulating hormone, their estradiol before the procedure, the 6th month, 12th month, and the 2nd year. So they found no significant difference regarding the level of these hormones, which proves that this does not affect the fertile ability of these females. Also, another research showed that 100 females who had pelvic congestion and were unable to get pregnant, they performed selective embolization of the varices in the pelvis. So 72 or 75% of them got pregnant during the 1st year after the procedure. So in my opinion, we can let's say we can compare this disease with the varicocele in men. And we are treating varicocele in men because of infertility. Why not treat the pelvic congestion in women for the same indication? So my answer would be treat them all with no regrets.
Thank you.
Very interesting presentation. Congratulations. Could I ask you about the embolization materials? What are the possibilities, the variety?
Yes. You saw on this presentation, this is the Balkan version of the procedure. We're using as few coils as possible because of reimbursement issues. If we lived in a perfect world where we had any material we could use, of course, the physicians throughout Europe and USA, they're putting like 20 coils alongside the whole ovarian vein. So they're covering with coils the whole ovarian vein. But in order to save some material, we're putting some foam, and in this way we can implant only 3, 4, or maybe maximum 5 coils.
You did the so-called sandwich therapy.
Exactly, sandwich technique, which is very useful for our reality. Professor Bizdes will be with us maybe tomorrow or in Sunday. He presented a very nice case with pelvic congestion syndrome where he put maybe 20 or 25 coils into the ovarian vein, and it looked very dramatic. I regret I didn't put this picture. Very effective. Of course, the risk of recurrence after putting so many coils and embolizating the whole ovarian artery is practically zero. With our approach, maybe there is some small chance of recurrence, but I believe it is negligible.
Is there any experience with onyx embolization material?
Yes, there are many authors who share very nice experience with Onyx, but these are only single-center trials, and unfortunately there's not much evidence in the literature regarding the use of Onyx. But they share their personal experience, and it was very positive.
There is a question.
It's not a question, it's only a comment. You mentioned Onyx, and we are treating dural fistulas and ADMs, several ADMs, using Onyx, squeeze, but very often glue, and there is no reimbursement issues. It's very effective. Are there some? Thank you.
Are there some publications where the authors used glue?
Yeah, there are some authors that are sharing the usage of glue, but if we want to use the glue, the Turkish glue or Medtronic glue, doesn't matter, you should be able to compress the veins so it sticks together. That's my opinion. It's very, very difficult to compress the vein in the pelvic region. That's kind of obvious.
Or some combination, for example, coils and glue?
Yeah, that sounds about right. To be honest, I don't have any experience using glue in the pelvic region, but this is absolutely possible. Another option, which I saw 2 weeks ago, is that Professor Tessari, who is the inventor of the so-called Tessari foam. We have a method to create a foam from the sclerosing agent with air. So he presented his experience with putting glue after performing sclerotherapy, foam sclerotherapy. So he believes if we put foam first and glue second, that we highly increase the effectiveness of the sclerosation. But this is for the varices of the lower extremities, not in the pelvic region.
Thank you very much.
Okay, thank you very much. Great. Very interesting. I have the information that our colleagues are ready to show us the progression of the life case. In interest of the patient, if you agree, it's better to take a look what is happening in Saint Anna. Professor Velchev, do you hear us?
Good evening, everyone. Once again.
Yes. Hello.
Case, patient which was tested after a stroke, actually before 6 years ago, 2014, on the left side, and then he was asymptomatic for 6 years, and now we have transitory scaling attack on the right, and the Doppler showed us that the stent on the left is quite degraded, no problems, but we have new vision on the right side.
Was it a wall stent, the first one?
Wall stent, the first one, wall stent. And I don't know whether you can see, we have on the right, which is what we have as a vision now, is a long vision. But if you want me walk into the case, I want to show the few things. First of all, we work from the right radial. Okay, that's our vision. It's relatively long, no calcium, a little bit plastic. It is almost all in the internal carotid. Intracranial, we don't have good flow in the anterior, which is what we can expect for the lesion which is hemodynamically symptomatic. And then we put the spectra on sheet, and with a long seam happens to cut through, we can cut right away after the gate.
Vasco, are you from, sorry about interrupting you, are you from radio or brachial?
Advanced telescopically the sheet, now we are in the right carotid. So that's our picture. We are in this stage. We have the positioning of the 6th range destination. We are ready to start the procedure. The patient is loaded with heparin and clopidogrel and aspirin, and we plan to put a C-guard stent. Mostly because the patient was recently symptomatic and we have reasons to believe that this lesion is highly emboliogenic.
And what about the distal protection?
First, we put our filter in, and then we stent, and we decide on a pulse dilation after. Do you have any suggestions?
You probably don't hear me. Do you hear us?
Now I hear.
Okay, great. Interesting case. You mentioned it's a symptomatic patient, probably with high surgical risk.
No, it's not high surgical risk. It's symptomatic, recently symptomatic. It was the TIA a week ago, but with just paresthesia and slight weakness in the left hand.
Great. And you have an elegant approach from the right arm, probably radial or brachial?
Radial.
Radial, great.
We have full femoral for the left and radial for the right.
Very good. Okay, so I can guess you are planning to put a filter distally as a distal protection.
We're planning to put a filter wire, and now
Filter.
I'm taking my roadmap. Не върдай главата, ако обичаш. Добре, завърти наляво и не мърдай, моля. Добре, не мърдай главата. И сега ще отсетиш на обегряване. We are ready with our filters and our stent. We prepared them previously as we usually do for the carotid case. And now we are going to place a distal filter. It is a filter wire of Boston.
Yeah, it's a very low profile filter with a good mesh. It's an elegant option.
The whole region, going straight here.
Would you consider in this situation proximal protection, symptomatic patient?
Maybe we should, but that's not our practice.
Yeah, we know, for example, our Italian colleagues for symptomatic patients especially, they prefer proximal protection in order to avoid at the possible extent the embolization, the micro embolization.
The strategy usually for this guy is a filter and double mesh stenting. We rely on a double mesh to protect us from the emboli for the pulse dilation, and we know that the C-guard is very, very protective because the minimal lumen of our pores is quite low.
Yeah, it's about 60 microns, and it's probably very important to emphasize that the mesh, the additional mesh of the C-guard is outside. It means the nitinol mesh of the stent, the metal, is pushing in.
The stent through the lesion.
Yeah.
Now we are starting to deliver the stent.
So I was mentioning that the nitinol structure of the stent is pushing the mesh over the plaque, so it's in fact stabilizing with the dense mesh stabilizing the plaque as well.
We would like to do it slowly, okay? We want to cover at least 1 centimeter after the lesion, and we would like to cover at least 1 centimeter post-lesion, because from the CT, usually in this situation, we know that the plaque is extending a little bit more than it looks on the angio.
Absolutely right.
So that's why when we cover the whole region, we feel safe now. I will fill just the stent for you. Okay, you can see the stent. It is very nicely disposing full length of the lesion. And now we feel safe to pulse dilate, even we are with the filter and not with the proximal protection. We have 4.5 balloon for pulse dilation, and we will go for high atmospheres. We don't routinely put atropine inside.
Do you pre-treat with atropine or only? No. Okay.
Only if we see a lot of calcium. We are in. We are ready. Now. That's it. Ready? Now we shall put some atropine inside because our rate is 53,
No.
but the pressure went a little bit down.
Okay. In our experience, we are generally for all the involving the bifurcation lesions that need balloon inflation, we put 1 milligram atropine as a prevention.
I think it's safe now to repeat the filter.
Very good result, the so-called surgery-like.
And the filter dwelling time is something like a minute and a half for the most cases.
What usually do for the hypotension? You mentioned that the patient is relatively hypotensive. We know that the atropine is not sufficient for hypotension correction.
We wait a little, so usually we give it a few minutes, and then we put the volume inside.
Yes, some volume putting is necessary probably.
Как си? Вратът те заболя, да. Нормално е да боли врата. We still have a low pressure.
In our experience,
we think we pull away the sheet and then we put some volume.
Yeah, exactly. But sometimes even the volume is not sufficient, and
now we want to do a final shot.
Okay.
Just to see the intracranial part. Не бързайте момент. Okay, I think we're ready here.
Yeah, very nice, straightforward case.
Валентине, болката намалява ли? Да. Добре.
In fact, the pain in the neck can continue even for several days, so it's
sure.
especially in calcific lesions.
Even if you are not very aggressive in the post dilation, so we went for the 4.5 instead of 5.
Yeah, good point.
Now we have pressure which is a little bit higher, 80 by 40. If we wait a little bit longer. Може ли да движиш сега ръката? Другата ръка. Добре. Как си? Горе-долу свършихме. Сега само трябва малко кръвното падна. Трябва да го качим и
And you mentioned the contralateral wall stent is fully patent without any pathology?
Contralateral is patent on Doppler. We have a custom lever to check it, so we never do an angio for the vessel which is patent on the echo, but not the other way around. Sometimes we do an angio for the patent which is stenotic on the echo.
Okay.
So in this situation we have symptomatic, highly symptomatic lesion, and we don't want to mess with more contrast. I think that we will have to wait a little bit, but we will put out the sheet. The patient is awake and we have no neurological symptoms. So I think we are ready now. And while we're waiting, I would like Dr. Stoyanov to show you a case which was devoted to the previous session.
Let's allow the colleagues in the audience to ask questions, probably comments.
Okay,
somebody.
Валентине, готов. Сега, имаше голямо стеснение такова, който има малко като мека плака вътре. Сложих един специален стент, той сега ще натиска артерията и може да се боли известно време. Най-вероятно до 2-3 часа тази болка ще изчезне, не те притеснява. И тук на ръката ще сложите една специална превръзка, но въпреки това ще помоля поне час-два да не ставаш от хребата, след това вече може да ставаш. Okay, Ivo?
Okay, great case.
Actually, for the last couple of years, we're trying to do mostly symptomatic patients. So we kind of shy away from the asymptomatic aortic stenosis. And like in this case, we have some data from the Doppler and from what we see on the angio that actually the lesion was quite soft. Even if we have, as you notice, a very severe hemodynamic reaction, and maybe you're right, maybe we should put atropine before, but our routine is to put it only if we need it.
You mean you rely on the color duplex, or also you perform CT angio in some cases?
We rely on color duplex because through the years we already know which sonographer we can rely on, and if we know the sonographer and we verify the results before, we are sufficient with the Doppler. So can we now move to the other screen?
It's there.
Okay.
So you mentioned you have a pre-recorded case?
It's a case pre-recorded because it is connected with somehow with the session for the dialysis intervention.
Okay.
Готови сте? Не, той е готов.
Аз мога да говоря. Hello? Can you hear me?
Yes, we hear you very well.
Nikki?
Yeah, it's a pre-recorded case about one 73 years old female patient. She is on hemodialysis for 1 year, and a year ago was implanted central venous catheter. The catheter is working extremely well, but the patient developed superior vena cava syndrome with swelling of the neck and the head, and in the last few weeks, shortness of breath. The patient was referred a few weeks ago for us for angio and to deal with the superior vena cava syndrome. This is the first shot, not so informative, but this is the second one. As I showed you during my presentation, our regular setup, it's a 0.35 wire, and we are pulling back the catheter, and we are using the catheter for contrast media, and you can see the really critical lesion with fibrin sheet formation in the superior vena cava and vena azygos hypertrophied. We used 8mm balloon for dilatation. After that, we had good results, but after that we took a 14mm balloon, and this is the dilatation with the 14 by 60. We are waiting for the fully expansion of the superior vena cava, and you can see we reach our goals. We finally it was successful finally. This is the shot after the dilatation, and the result was acceptable for us. We insert back the new catheter in the right atrium, and we were thinking that our job was done. But unfortunately, after the first dialysis, the patient complained of really severe shortness of breath, and her neck and head had swelling, and we decided to perform a second procedure with the femoral approach to recanalize the superior vena cava and to find the better way and to have a connection with one of the both innomina veins. Our setup was a 7 French 65 long centimeter destination sheet, and this is the diagnostic angio. We have a complete occlusion of the superior vena cava. This is our setup, 7 French 65 centimeters destination, and support catheter, 5 French Navi Cross from Terumo. We used regular um, white wire from Terumo, and we passed next to the catheter, next to the dialysis catheter. You can see on the screen, we had a really good support from our setup from the destination and Navi Cross. We passed into the subclavian vein, and this is the angiogram to prove where we are. After that, we had several balloon dilatations with balloons 5O and after that 8. This is the dilatation with and attempt to gain the space with 5O balloon by 120. This is the very first dilatation. After that, we were able to go to the subclavian vein, and we inflate the same balloon one more time. This is the dilatation. Several dilatations in the and this is the first result. After that, we decided to take this 8 millimeters balloon. And finally, I decided to take another 14 millimeters balloon, and this is only in the part in the superior vena cava. And we have several angiograms from the subclavian vein, after that in innomina vein, and finally in superior vena cava. And we decided to stop because the patient felt some pain during the inflation with the 14 millimeters balloon. And we were thinking that the job is done, and it was, because the swelling of the neck and head disappeared the same day, and the patient was discharged and the next day, and with extremely well working dialysis catheter, and solve the problem with the superior vena cava syndrome. And that's the case. We combine the antegrade and retrograde techniques, but not in the same day, because usually when we inflate the proper balloon in the superior vena cava, everything is fine. But in this case, it was we need to inflate next to the catheter. But finally, we have a happy end.
Nikki, do you think the balloon dilation, the balloon angioplasty will be enough, let's say, to prevent restenosis?
Nobody.
No.
No. No.
Ivo, do you hear me?
Yeah, we hear you very well.
Balloon is almost never enough to prevent restenosis, but in case like this, we want to have a patency of the catheter first, the relief of the swelling of the next second, and usually with times some we can expect some more collateralization, and sometimes restenosis goes asymptomatic. So we depend. Once we put a stent, it will almost 100% restenosis.
Yes, so yeah, in our experience is quite similar. We have discussed that the venous stenosis are not plaque stenosis, it's a stenosis of the vessel wall. So the probability of recoil, that is the first mechanism of restenosis, is quite high. And definitely, I don't know, it's probably not 100%, but at least 50% of this stenosis, they have restenosis after balloon dilation. Okay,
so
good.
is our experience.
Yeah, interesting.
As I said, we are goal-oriented and now the stenosis-oriented. If the patient is feeling fine, the neck is not swollen, and we have a patent catheter, then we are happy and we declare victory.
And what stent would you implant in this region?
If we have a symptomatic patient with recoil and after dilatation, we usually use a bare metal stent to reconstruct the superior vena cava.
Any big stent that you have on the shelf, but be very careful with the wall stent.
Yeah.
Because the wall stent can jump, so that's the problem. If you put a wall stent, it should be, it can be tricky, but otherwise, sometimes we put a big stent of Cook, Z stent, Zilber.
Yeah.
Sometimes we put Protégé, but Protégé,
no, the radial force of Protégé is not good.
So it's sometimes not enough.
Yeah. In fact, we have in Bulgaria, fortunately, the Sinus XL that is indicated for venous application, and in this situation, we would put a Sinus XL.
Sinus should be very nice approach, yeah.
Absolutely. Okay, thank you very much.
Okay.
Very interesting cases. Well done. Great job. Congratulations.
See you soon.
Okay, thank you. See you. See you later. We can continue probably.
The next presentation, deep vein thrombosis interventions. Dr. Nikov, the floor is yours.
Just a second, probably Dr. Londero, you wanted to comment something regarding the case? Yes, microphone please.
In my experience, I tried not to use stents in this area. The stent at the end crash all the stents, and you put one stent, two stents, three stents, four stents. You have a multiple stent layer, and the problem continues. Then I prefer to use plain balloon once a year, twice a year, but I think that stents are not good for this situation.
Yeah, as I mentioned, in fact, the recoil and the stenosis is very, very rigid, and there is sometimes there is not possible to expand well the stent. In case we cannot expand well the stent, the thrombosis of the stent is almost done. Almost the conditions for stent thrombosis are there because of the stagnation and under expansion. So because of that, when we are implanting stents in this region, we implant stents. In half of the cases, we implant stents, but we are trying to use non-compliant balloons in order to achieve better stent expansion. On such a way, it's reducing the probability of restenosis, and of course, anticoagulation is important.
The problem is that the movement at this site is important. Then the crash of the stent at the end is the rule.
Yeah. Okay, yeah. Nice point. Okay, if no other, Dr. Nikolov.
Thank you, Professor Petrov. Professor Staneva, thank you for the opportunity to share my experience with dealing with deep vein thrombosis. The purpose of this presentation is to show our experience with the interventional and surgical treatment of acute DVTs, and it will have two parts: iliofemoral DVTs and upper extremity DVT. As we know, iliofemoral DVT treatment is the main treatment is anticoagulation, which prevents very well the pulmonary embolism and recurrent DVT. But the problem with anticoagulation is that it cannot restore adequate venous patency, which results in time in high incidence of post-thrombotic syndrome, which especially in iliofemoral localization of the disease is up to 75%. And in 2 or 3 years, many patients have this picture. The reason for development of post-thrombotic syndrome is the presence of the thrombus in the vein, which leads to inflammatory reaction, vein wall remodeling, and finally residual venous obstruction and injury of the valves with reflux. So how could we prevent post-thrombotic syndrome? The early thrombus removal strategy was proposed, and it can be achieved with either surgical thrombectomy or any catheter-based techniques, including catheter-directed thrombolysis, pharmacomechanical thrombolysis, and entirely mechanical thrombectomy devices. What the guidelines says, in selected patients with symptomatic iliofemoral deep vein thrombosis, early thrombus removal strategies should be considered. This is based on the other hand, it is not recommended for more distal localization of the thrombosis, including femoral, popliteal, and calf veins, where the treatment should be anticoagulation. This is based on several randomized controlled trials, which show that in iliofemoral DVT, the risk of post-thrombotic syndrome is decreased with treatment of the thrombosis, early treatment of the thrombosis, and it is especially well demonstrated. It very well lowers the moderate and severe post-thrombotic syndrome in time. But there is always cost, and the cost is increased bleeding of these procedures. So if we think how to reduce the bleeding risk, we know that the bleeding is a result of use of fibrinolytics, so maybe entirely mechanical thrombectomy or very reduced amount of fibrinolytics, or maybe surgical thrombectomy can reduce this bleeding risk. What we do, what is our practice, is in cases of iliofemoral DVT confirmed by duplex, to perform CT phlebography as well as laboratory tests and early initiate anticoagulation. And if the patient is suitable for surgical thrombectomy, this is what we do. But we do it in an operating theater with a C-arm. It is a hybrid procedure under control, and always finish with angiography to check for underlying disease. This is one of our cases, a 56-year-old female with 1 day after high dose of corticosteroid administration for multiple sclerosis. She got painful, swollen left lower limb, and duplex and CT very well demonstrated left iliofemoral phlebothrombosis to the May-Turner point. We performed surgical thrombectomy under general anesthesia through left groin cut down with distal thromboextraction by milking of the calf. and also with thrombectomy with Fogarty catheters from distal and also from proximal direction. And this is the completion phlebography after thrombectomy only. You can see some residual thrombosis in the common iliac vein, and probably compression, diseased, chronically diseased vessel. After ballooning with 40 millimeter balloon, this is the result, and this is after putting wall stenting. The next day, the vein was completely patent, and the edema was disappeared. This is the common femoral vein. At 3 months follow-up, the patient has no complaint, and you can see the well-patent iliac vein with stent in it. The second case is of a 14-year-old female with 16 days of back pain irradiating to the leg, which became later swollen. She was on oral contraceptives for ovarian polycystosis. CT shows very well iliofemoral DVT with compression of the left common iliac vein and some engagement by the thrombus of the inferior vena cava. So we did almost the same, excuse me, but this time, because there was partial thrombosis in the IVC, we put from the right percutaneous axis occluding balloon in the IVC, temporary, to protect embolization and to facilitate thrombectomy from the left iliac vein. This is the Reliant balloon we use. You can see it in the upper part of the picture coming from the right groin. It is deflated at this position, at this phase of the procedure. Predilatation of the left common iliac vein. This is after dilatation. You can see that there is definitely compression by the right common iliac artery, and this is after stenting. Our experience is quite limited. We have only 4 patients with iliofemoral DVTs treated this way, from 19 to 56 years, 1 male. In 2 of the cases, we had to stent residual stenosis and compression lesions. In 1 patient, we had a combined procedure with arterial patchplasty of the common femoral artery and SFA recanalization. In fact, this lady had very painful critical limb ischemia combined with iliac vein thrombosis of 1 week. And after 3 months, she came back with occluded SFA, but the vein was patent and she was in good condition, not requiring any further interventions. So, in fact, there are no randomized studies comparing endovascular procedure with open surgical thrombectomy. There is 1 study we found with 71 patients treated for iliofemoral DVT, which shows no difference in terms of patency, reflux, and development of PTS at 2 years between surgical and catheter-based techniques. And the surgical group showed lower rate of bleeding complications, shorter procedure times, and reduced length of stay. In conclusion, we can say that modern surgical treatment of iliofemoral DVT is a hybrid procedure combining relatively fast open thrombectomy with endovascular adjuncts to treat the underlying lesions. It has the potential to reduce the PTS without increasing the bleeding risk. In carefully selected patients, it is feasible and quick way to return patients to normal activity, and it is, in my opinion, a viable option until new percutaneous entirely mechanical thrombectomy devices became available at affordable price. So let's go to the other part of our practice. This is the upper extremity DVT. We'll talk about the Paget-Schroeder disease, which is the primary effort thrombosis. It's a rare condition affecting young patients where repetitive compression of the subclavian vein between the clavicle first rib, scalenus anterior, and subclavius muscle leads to acute thrombosis. And there is a high risk of recurrence and development of post-thrombotic syndrome in these patients because the compression is ongoing with time. There are several options, including anticoagulation, catheter-directed thrombolysis, surgical decompression, and venoplasty, and any combination of all of these. The diagnosis is clinical. Is usually confirmed by duplex. Phlebography confirms the diagnosis and is a step toward treatment. Here you can see occlusion of the subclavian vein and secondary of axillary vein. The guideline says that for patients with primary upper extremity DVTs, anticoagulation should be initiated for 3 months, and in selected young and active patients with upper extremity deep vein thrombosis with severe symptoms, thrombolysis may be considered within the first 2 weeks. What we do usually is put a catheter through the basilic vein in the axillary and subclavian vein and perform 24 hours catheter-directed thrombolysis. For a period of 18 months, we have 7 patients. The onset of the thrombosis was up to 12 days. This is how it looks, a very, very short occlusion of the subclavian vein in this case. After 24 hours, we usually check the result. Most of the time, there is a quick clinical improvement. Almost full restoration of the lumen was seen in 5 patients, partial in 1, and 1 remained occluded after 24 hours. It's very important when there is a good lysis after that to do phlebography in several positions of the leg. You can see there is quite good lumen after fibrinolysis, but when you do the same in abduction, you can see the compressed subclavian vein between the first rib and the clavicle. So what to do next? There is no clear recommendations. We can perform anticoagulation, go on with anticoagulation, do decompression immediate in 1-2 days or delayed. And because sometimes there are chronic changes in the vein, open patchplasty at the time of decompression or PTA stenting is also considered. The guideline says that for patients with upper extremity deep vein thrombosis treated with early thrombus removal, first rib resection may be considered if there is clear evidence of venous thoracic outlet syndrome. So what we do is always discuss with the patient. Of these 7 patients treated with thrombolysis first, 3 patients remained on anticoagulation only, most of them because they refused further invasive treatment. In 2 patients, we did immediate first rib resection through subclavian approach. And in other 2 patients, delayed decompression. One of them was done by our colleagues, thoracic surgeons, thoracoscopically, with very good result. And in 1 patient, during the decompression, we had to perform patchplasty because the vein was very, very sclerotic and thin. This was also with very good result. At the follow-up, up to 18 months, 5 of the patients remained asymptomatic. We had 1 recurrent DVT in a patient without decompression during his anticoagulation 3-month period, and one patient developed superior vena cava syndrome 2 months post decompression, which was result of mediastinal non-Hodgkin lymphoma, which was probably missed during the initial diagnostics. This is a result after 9 months. We suppose that probably there should be some residual stenosis in this patient, which was not confirmed. Very, very good result after first strip resection only. In conclusion, Paget-Schroeder syndrome affects young patients and carries a high risk of disability. CTD is more effective than anticoagulant therapy in preventing PTS, and surgical decompression of subclavian vein improves the long-term prognosis. Given the lack of conclusive evidence and direct comparison of different algorithms, we believe it is necessary to discuss all therapeutic options with the patient and propose an individual approach in every case. Thank you for your attention.
Thank you, Dr. Nikolov. Dr. Voce? Yes, of course. Microphone, please. It's probably better the microphones to be around.
Dr. Nikolov, congratulations on your great results.
Thank you.
I have one question for you. I know we're always thinking about cutting costs, reimbursement issues, or anything.
You know.
But do you think there's a place for the use of IVUS in this situation where you can properly size the venous stents, especially in the iliofemoral region? Because maybe sometimes after thrombectomy there's a spasm of the iliac vein and the sizing of the stents might,
of course,
be difficult.
You're absolutely correct. The IVUS is something you must have in armamentarium when you're dealing with deep veins, because we don't have, we wish, but we don't have. We are doing very, very accurate measurements on the CT, especially in the acute cases like this. The vein is full of thrombus, and you can measure the maximum diameter of the vein and plan well what kind of stent to put to be big enough, not small, not to migrate after that, and so on. It is more tricky in chronic cases when you have to achieve good lumen with adequate pre-dilatation, and after that put the desired stent.
And did you find any May-Turner compression with your iliofemoral DVTs?
In 2 of the 4 cases we done.
And you stented them?
Yeah, we stent them.
Thank you.
Good result?
Yes, very good.
I mean, long term.
Long term, yes. The follow-up is for 9 months for the one of the stented lady, and the other one is almost 30 months, and they are patent and very well doing.
Thank you.
Okay.
Thank
you.
Other
Thank you.
questions and comments? Thank you, Dr. Nikolov. The next presentation, post-COVID thrombosis management, Professor Petrov.
Thank you, Professor Staneva. I will speak about, probably all of you are fed up with COVID, I'm absolutely sure. But okay, let's take a look at the contact points between our endovascular course and COVID, if there are. So, the COVID-19 pandemic, in fact, involved almost half of the population on the Earth, causing more than 6 million of deaths. It's clear that it's a severely acute respiratory syndrome with several very important complications due to the huge inflammation. And this diffuse endothelial inflammation have a direct relationship to vascular pathology, especially endothelial dysfunction, disrupted membranes, microangiopathy, and finally vascular thrombosis. Because of this cascade, in fact, the main complications are due to cardiovascular or neurovascular complications through the thrombosis state. And it's probably ridiculous, but only 2 months before the COVID pandemic started, there was a very nice meta-analysis by Musher showing that inflammation by itself is one of the most important predictors of thrombosis, of vascular thrombosis. And in fact, he named not only the mechanism of thrombosis in inflammation, so he detected the viruses that are most prone to cause the so-called inflothrombotic complication. These are not only the COVID group, but also the influenza, cytomegalovirus, human parvovirus, and so on and so on. So, the thrombosis triad Virchow is more than clear. In fact, the COVID-19 infection has led many people to have the necessary conditions for the triad Virchow, like immobility, dehydration, procoagulation status, and so on, in order to have these conditions and thrombosis finally. But putting apart the venous thrombosis, for the arterial thrombosis, the mediators, the so-called cytokine storm, and also the increased tumor necrotic factor and hypothetical endothelial dysfunction also has led to activation, the extrinsic pathway of activation, and also to arterial thrombosis, not only venous thrombosis. And as a final step, the formation of deep venous thrombosis, pulmonary microthrombi, intravascular coagulopathy, and myocardial injury had led to involvement of the pulmonary circulation, myocardial circulation, and peripheral circulation into the pathology of thrombotic complications. Regarding the laboratory test telling us if a particular patient with COVID has a thrombotic complication, they are not only the D-dimer, but also the fibrin degradation products, the thrombocytopenia, and also the changes into the thrombotic time and the APTT. In myocarditis, of course, we were searching for the interleukin and the troponin increasing levels. Regarding the prevention and the treatment of prothrombotic state, of course, it's important the medication, and more and more COVID guidelines had emphasized on full anticoagulation on the early stage. So full anticoagulation, not prophylactic, full therapeutic anticoagulation in order to prevent thrombotic complications. And nevertheless, still around 30%, even in full anticoagulation, they have thrombotic and thromboembolic complications. In fact, there was, even in the first several months after the pandemic started, a German and Italian team showed us in autopsy the deep venous thrombosis is present in more than 40% of the patients that died. And because of that, there were guidance regarding the stage of the infection, the anticoagulation, and the fibrinolysis. So the next step, in case the full anticoagulation is not efficient, fibrinolysis is the next step. Thrombolysis or fibrinolysis, of course, carries the risk of bleeding. Unfortunately, the COVID-19 subjects involved by the infection subjects, they have in one and the same patient, and we had more than one such a patient, in one and the same patient to have thrombotic and bleeding. And it's in fact absolutely contradictory what to do in such patients, to thrombolyze in order to remove the thrombus, but he will die by the bleeding. So in this situation, it's quite difficult to have the right decision, and I will show you some possibilities, some opportunities. Here is a simple 48-year-old non-smoker male with COVID-19 infection with elevated D-dimer, and he had deep venous thrombosis that was proven by the Doppler, and he was fully anticoagulated, and because he had not only DVT, but he had, in fact, thrombophlebitis. He had also antibiotic regime, and he did well after this treatment. What about the concomitant pulmonary embolism? We know that the deep venous thrombosis and pulmonary embolism are the two sides of the one and the same coin. So in case there is a DVT, more than 90% of the people will have pulmonary embolization. Of course, the D-dimer is, and the graduation of the D-dimer is one of the main, let's say, discrimination to decide who is the patient at higher risk, but not only the D-dimer, also the echocardiography will show us the distension of the right ventricle, the tachycardia, the hypotension. So all these features that are absolutely clear even before the COVID-19 pandemic and the pulmonary embolization. It's another case of 84-year-old lady with shortness of breath and weakness in early post-COVID phase, 1 month after the COVID. She presented with a typical distension of the right ventricle, right bundle branch blockage, one Q3, T3 pattern on the ECG, and elevated pulmonary pressure. As you can observe, she has a very massive thrombotic burden both on the left and the right side of the pulmonary artery. In this situation, fortunately, she hadn't too much increased risk of bleeding, but nevertheless, in our experience, we have more than 870 patients treated with thrombus fragmentation, like I'm showing here, thrombus fragmentation with the pigtail. And after putting the pigtail both sides and fragmenting the thrombi, we leave the catheter inside, the pigtail catheter inside overnight for more than 12 hours to put 1/3 to 1/4 of the full dose of the fibrinolytic. And in this case, it resulted efficient with full restoration of the flow into the pulmonary artery. Is there another option? I mentioned already that the thrombolysis is a very good option, but only in patients without increased bleeding risk. In these patients, the mechanical devices are giving chance of surviving. You can observe a huge, almost totally precluded pulmonary artery on the left side with a huge thrombotic burden. A 75 years female with loss of consciousness. In fact, she had cardiogenic shock of pulmonary source, pulmonary thrombosis source. So in this situation, we have used a combination of thromb fragmentation with the pigtail, aspiration, and super selective low dose, extremely low dose, only 50 milligrams of fibrinolytic. So this is the position of the catheter, and this is the Aspirex thrombi suction, both on the left and the right side. It's a 10 French catheter in order to aspirate more. And this is the combination with the fragmentation of the thrombi with the pigtail, like on a our usual way. And on the right side is again the aspiration with the mechanic catheter with complete restoration of the flow, as you can observe on the left side. Another case, in this case, it's a peripheral one. The 72-year-old female, she had a history of femoral stent, SFA stent implanted 2 years before this procedure, and during the last follow-up check, she had absolutely patent stent and no restenosis with 0.9 of ABI. And it's one of the many patients that had excellent follow-up, and around the COVID-19 infection, they had thrombotic event. So the lady, unfortunately, had a huge thrombotic burden all the way down from the ostium of the stent to the popliteal artery. In this case, again, we had used Rotarex in order to remove the huge thrombotic burden. This is, you see the tip of the Rotarex. moving go and back in this stent, and after the balloon, additional balloon dilation with a long 300 centimeters long balloon, we succeeded to have recanalization and flow restoration in this lady with a thrombotic stent occlusion. And regarding the heart, it's unfortunately it's not protected. The inflammation, this inflammation storm, cytokine storm, unfortunately is affecting also the heart. And this is one of the pandemic of the, I will show in my next presentation that it's not only infection pandemic, it's also cardiovascular disease pandemic that is caused by the COVID-19. So like I have shown, the arterial thrombosis is also very typical. It was the deep vein thrombosis and the pulmonary embolization became popular, but in fact arterial thrombosis is also a problem. And you see that the arterial thrombosis are, in fact, the characteristics are more proximal thrombosis and big vessel thrombosis that otherwise in the daily practice is very rarely seen. So in most of the cases, the arterial thrombosis is caused by critical stenosis. In this COVID-19 situation, we have thrombosis, previously uneventful thrombosis of big vessels and many sites, like in this situation, the iliac and the popliteal artery. Regarding the acute coronary syndrome during the COVID-19, there was a mimicry of reduction of the acute coronary syndrome. That is shown by the American and the Italian experience. The hospitalization for acute coronary syndrome during the COVID-19 pandemic decreased dramatically. But why? Not because the acute coronary syndrome disappeared, just the opposite. The patients with acute coronary syndrome had increased by number, but they were, you see here, home. They were having acute coronary syndrome at home, and they were dying and home. And this is also showing in several Italian cities like Pavia, Mantua, and so on, that the cardiac arrest due to acute coronary syndrome, in fact, increased during the COVID-19. So it was absolutely not true that the acute coronary syndrome was lower frequency. Typical case, we had, since long time ago, we didn't have in one and the same patient thrombosis of two arteries. In most of the cases, the myocardial infarction is caused by thrombosis of an artery, one artery. During this period, in many cases, at least 5 cases I can remember now, we had in one and the same time thrombosis of two arteries in one and the same time. And in this situation, the best is to remove the thrombus. So we can see here a thrombus burden into the LAD. And after the thrombus aspiration, you see how big is the thrombus burden. It's a long thrombus, and this is the achievement of TIMI 2 to 3 flow after the thrombus aspiration. And of course, after the implantation of the stent, it was fully restored. It was the treatment after all these treatments is very important. So full anticoagulation together with double antiplatelet in case of stent implantation is absolutely crucial. I will skip this case. It's just a simple case of COVID-19 caused thrombosis of the right coronary artery, of course, protected by pacemaker temporary. So COVID-19 brought a big burden to the world and to specifically cardiovascular patients. Cardiac manifestations of COVID-19 include myocarditis, demand ischemia, myocardial infarction, and arrhythmias. Aspiration thrombectomy may be a valuable approach to treat COVID-19 patients suffering from a significant burden of pulmonary embolization and also arterial thrombotic complications. And thank you very much for your attention.
And thank you, Professor Petrov. Congratulations on your very interesting presentation. Do you have any questions, comments? If you want to continue with symposium.
Thank you. I would like to ask Dr. Reed to join us for the welcome. Dr. Reed.
Yes, just two.
Yeah, okay, great.
Can you hear me? Good, I can hear myself. So I'm delighted to be here. I came approximately 10 years ago, more 12 years ago, to Sofia, first of all, and met Ivo Petrov. And I'm very, very pleased to be moderating this session. Now, it has been assisted by Evo Pharma. And Evo Pharma is originally a Swiss-based company, a pharmaceutical company started in 1959. And it's become very involved with cardiovascular imaging particularly, and intravascular ultrasound. Now, intravascular ultrasound is a guidance system, catheter-based guidance system, which really came to the peripheral side from interventional cardiology approximately 30 years ago. And I think it's fabulous. I've been very interested in it ever since I worked with Dr. Dietrich at the Arizona Heart Institute, who was one of the pioneers, along with Rod White at UCLA in Los Angeles. But also in Holland, Gussenhoven was very involved. And yet, Eastern Europe, even 30 years ago, was a proponent of IVUS. So, Eva, would you like to tell us about the latest addition to this, which is really high-definition IVUS?
Thank you, Dr. Reed, for your kind introduction. I'm glad, in fact, Dr. Reed is helping us so much. He's one of the most prominent experts in IVUS for peripheral interventions, and definitely your support is crucial. Thank you for that. One of the ex-presidents of the International Society of Endovascular Specialists, so it's an honor for us, for you to be here. Thank you. So, what about the ultrasound technology to show more about vascular pathology? In fact, the technology of intravascular ultrasound evolved tremendously during the last decades, in fact, more than 30 years. Donald already mentioned. In fact, what is angiography? Angiography, in fact, is a shade of a vessel full of contrast. And because of that, following this shade, we cannot see too much. So we cannot see the wall, we cannot see the circumference. So in complex cases, mainly in complex cases, we need more. We need more image. We need more image of the vessel, of the wall, of the composition of the plaque. So we need more to decide what kind of treatment to do. I'm starting with the cardiology guidelines. The cardiology guidelines are absolutely categorically advocating the utilization of IVUS, especially in left main with class 2A, and especially in left main bifurcation. Why? Because the left main bifurcation, of course, for PCI. Left main bifurcation is a complex lesion. And in order to increase the probability of good results and to reduce the probability of restenosis, the IVUS is the perfect tool to show us what kind of stent, what diameter of stent, what angle arise in the side branch. So all this is leading to decreasing of the measured adverse cardiac events. There are many methods, and there are many devices. The IVUS is one of the too few devices that is changing, in fact, the results in terms of mortality. It's absolutely mortality, of course, is the biggest criteria in the medicine is mortality. So IVUS is very important, and because of that, not only into the American, but also into the European guideline, it's definitely a huge place of IVUS to optimize the results of left main. Another anatomical situation is the situation of spontaneous coronary dissection. In case the coronary dissection is not so occlusive dissection, it's not always very easy to show that this is the lesion that is causing the acute coronary syndrome. In this situation, the IVUS is crucial to show us the localization of the entry point, to show us the extent of the dissection, and to show us also the compression of the true lumen by the expanded false lumen. So we rely on the IVUS about plaque morphology, vessel diameter, area and lesion of length, vessel lumen, presence of arterial dissections. And in this situation, it's more than clear that these features not only they have to be used also in peripheral interventions, not only in coronary, because in all the vascular territories, head to toe, the IVUS has a crucial role to improve the results. This is the comparison between the angio, I was starting explaining the angio, and the IVUS. There are many advantages of the IVUS. In fact, regarding the stenosis, the plaque morphology, the thrombus containing or not, dissection, flow, and so only the flow is better seen by the angiography, simple angiography. All the rest is better seen by the IVUS. And for peripheral utilization, there are also trials and meta-analysis. What are the different trials examining different components of the procedure? So these trials are showing that there is a complication reduction. There is a reduction of the restenosis, target lesion revascularization. There is a very important better dissection detection, especially in SFA intervention, and there is a very good calcium detection. Calcium is enemy of the good result in peripheral endovascular intervention. And of course, it can be applied both on the venous and the arterial side of the vasculature. And especially like in our previous speaker, our friends have shown excellent results in venous pathology. But for example, in our experience, when we want to decide if a particular patient, in most of the cases lady, has a May Turner, we took the IVUS and we showed the IVUS the compression by the iliac artery over the iliac vein on an absolutely categorical way if there is a compression or there is not. So in such complex intermediate cases, both on the venous and the arterial side, IVUS is very, very important. And there are many meta-analyses showing the role, the impact of the intravascular ultrasound, for example, on femoral-popliteal level. I mentioned already there is a reduction of the target lesion revascularization. Why? Because the optimization, the index procedure optimization result is crucial for the reduction of the restenosis and reduction of the TLR. And because of the better reduction of the diameter and better evaluation of the stent that has to be implanted in case of a dissection with a flow limiting effect, all this improves outcomes with the reduction of the restenosis and reduction of the target lesion revascularization. Because the IVUS is so important, because of that there is a huge stimuli both by patient side and by pharma and company side of IVUS optimization. And during these years, there are many optimizations. And I will show several cases done with a special, very up-to-date new catheter, the Kodama catheter by Assist. This is a IVUS catheter that is really very modern. They started since the level of the previous IVUS machines, and they did something very interesting with a touch screen and a transducer and catheter. They have, in fact, had a step ahead regarding the user-friendly device. I mentioned already it's a touchscreen, it's a very low profile. The transducer itself is very close to the nose of the catheter. It allows us to go more distally and to evaluate the distal lumen vessel. And they have several very particular features like lumen view, silk view, showing us more increase the grayscale for inner blood speckle, showing, for example, thrombi or calcium. And it's very interesting because of the very low profile. The same catheter can be used both in coronary and peripheral vessels because of the only 2 French of distal tip entry and only 3.5 crossing profile, and it's compatible with 6 French guiding catheter, not sheet, guiding catheter. So I'm showing you several interesting cases. A 68-year-old male with multiple risk factors like the majority of Bulgarian patients, and a very interesting history. So right internal carotid thrombosis, left internal 50% stenosis, stenosis of the iliac and the femoral, and he presented with total osteoocclusion of the left common iliac artery with distal collateral filling, but with very low ABI, ankle brachial index, and of course, unfortunately, very short claudication. He had history of right side iliac stenting, and it's a very well seen that there is no collateral from the aorta and from the proximal vessels. And take a look on the left screen. Could you please play again the left panel? Мите, кликни левия панел да видят колегите, искам да им покажа нещо. In case they, I will try to go one back. Не дейте, аз ще се опитам да мина едно назад. Така. Take a look on this screen. No, it doesn't play. Unfortunately. In fact, I wanted to, I don't know why it doesn't play. Може ли да пробвате левия панел да се опитате да го плейвате? There is a very nice presentation of left internal mammary artery supplying the left iliac, the left femoral artery. It happened in many cases through the epigastric arteries in order to supply. Ако отидете с мишката на левия панел, би трябвало да се появи стрелката за play. Okay. Oh, yes. Great. Wait a little. Натиснете пауза и play. Okay. Doesn't matter. We'll show later. So we succeeded to recanalize, and I wanted to show you how, after filling the left common femoral, we punctured the picture of the artery because the pulsation was very weak. And after waiting the collateral filling from the lima, from the left internal mammary, into the late phase, we succeeded to puncture retrogradely the common femoral artery. So after the recanalization, both sides making a rendezvous technique of the 2 wires, we succeeded to have some recanalization, but still with a residual, very bad residual slow flow. And on the IVUS was very crucial to show us what is the extent of the dissection, and most important, what is the diameter of the vessel on the different level. So it was very important. You see how well is seen the transverse projection of the vessel in order to implant the right stent for this right vessel. And after implanting the 2 protégés, one 12 millimeter and distally 10 millimeter, this is the final result that we succeeded. And the IVUS control. So the IVUS control, you will take a look in several seconds with excellent expansion of the stent. And because of this good expansion of the stent, we had excellent flow into the target left iliac artery. The stent is coming. You see very well. The struts are very well seen. Okay. Jumping on the next case, 74-year male, again diabetic, hypertensive, with ischemic heart disease. Nothing new. It's typical. He had symptomatic left internal carotid artery stenosis, subtotal 99%, and 50% on the right side. You can observe how critical is the stenosis of the left internal carotid artery and how slow is the flow into the middle cerebral and practically missing into the anterior cerebral artery. So the IVUS was shown us really a subtotal stenosis. I mentioned already that there is a very low profile catheter. And despite this very low profile catheter, in fact, the residual lumen was almost big like the 2.9 French catheter. We used in this situation a trick, the so-called deep loop. Bifemoral, that is not very often used. In fact, in the type 3 aortic arch with very steeple angle of the left internal carotid artery, the access to the left internal, common carotid is not very easy. In this situation, we have used the deep loop with sitting of the sheet on the aortic valve. Fortunately, this gentleman didn't have aortic insufficiency, only aortic insufficiency he doesn't have. But we succeeded with the deep loop to cannulate the subtotal carotid stenosis. And after the exact closed cell design stent, it's important. You see how by the deep loop, the deep loop is very suitable because the left carotid in many cases is like a prolongation of the ascending aorta. So it's not very challenging to cannulate the left carotid. And after putting the stent, of course, under protection and implanting the stent, you see how good is practically TC3 flow. And this is the IVUS showing excellent expansion of this closed cell design exact stent that is covering very well the plaque in this critical stenosis of the carotid. And this is the removal of the catheter and the measurements of the lumens of the stent and the vessel itself. As a take-home messages, I would say that the IVUS is the ideal imaging tool to help guide complex peripheral endovascular procedures. IVUS-related complications are extremely low, especially with low-profile catheters with the Kodama. IVUS improves plaque understanding of the disease vessels and allows better procedure planning and completion. IVUS reduces the use, contrast agent, and total X-ray time. And the Kodama catheter is a next-generation, low-profile IVUS technology relevant with high resolution and applicable both for coronary and non-coronary pathology. And thank you very much for your attention.
Good, Ivo. So in summary, Ivo, you'd say that what intravascular ultrasound does is a great addition to angiography. It helps to assess the severity of disease before treatment and then check the accuracy of deployment once treatment has been done. And that this new system that you've been using for the last few years, to me, the advantages of it are, as you've said, the surface interface in the operating room for the operator is quite far better, but quite different from the other systems, and the high definition. Have you coped with reimbursement in Bulgaria? What about the Balkan area? Because on one hand, it is expensive to use an IVUS catheter, but if you've got an important case, a critical limb ischemia, a carotid stent, the important case is vital to get them done well first time. So what will you say about reimbursement?
Absolutely right. In fact, we are in a struggle with the National Health Fund regarding reimbursement of additional imaging and functional tools, functional like FFR. imaging like IVUS and OCT. And unfortunately, to date, there is still no reimbursement for these tools. But we are using always, in case the patient has necessity, we are using. I didn't mention, but in some cases, it's very useful, for example, for aortic dissection. In long-lasting aortic dissection, true false lumen is quite difficult to understand which is the true and which is the false lumen. And of course, IVUS is crucial to show us which one is the true and which one is the false lumen. And this is another option. And in such a situation, the reimbursement doesn't matter because the patient life is more important.
Has anyone got any questions? Well, if you have, Melina is over there from the company, and are many of you using this system in the Balkan area? Not yet, Melina. You've got plenty of room here, huh? Well then, thank you very much indeed.
Thank you.
Thank you.
Thank you for joining us once again. Okay, what next?
What's next? Hugo Londero.
We came to my teacher, Dr. Londero's presentation. It was a huge honor for me to be part of Dr. Londero's team for more than almost 2 years, in 99 and 2000. So everything that I have learned about interventional procedures are from Dr. Londero. Thank you for coming. Yeah. Several words about Dr. Londero. He's one of the pioneers of the invasive cardiology and endovascular intervention. One of the presidents, previous presidents of SOLACI, the Latin American Society of Invasive Cardiology. So one of the pioneers in the field. It's more than an honor to have you here. Thank you.
Okay, thank you, Ivo. Thank you to the organizing committee to invite me again to Bulgaria. Bulgaria is far away from Argentina. I can say that 36 hours traveling is not a short travel. We have different religion, we have different language, we have different history. But we have something in common. We are trying to do the best without money. And this is real difficult. Let me try to tell you something about that I know very well. I will speak about my experience in the practice of cardiovascular interventions in the last half of century. I began doing cardiovascular catheterization in 1966, 56 years ago, and then I see a lot during this time. Let me tell you a bit of history, something about the pioneers. In 1927, Egas Monins, a Portuguese neurologist, developed cerebral angiography by direct carotid punction. And in 1929, Reinaldo dos Santos, a Portuguese vascular surgeon, made the first aortography by direct translumbar puncture. At the very beginning, I see a lot of cases of those techniques, and be sure that they are not easy and that they have a lot of complication. But we don't, at this time, they don't know about selective angiography by catheterization. In 1829, in Germany, Werner Forsman performs the first human right hair catheterization by inserting a urologic catheter into his own antecubital vein and walking up to the next floor to obtain an X-ray imaging. Here you can see the catheter and Dr. Forsman with his nurse, which helped him, and both were quick off of the hospital as a consequence of this act. But 30 years before, Forsman received the Nobel Prize for the first catheterization. In 1953, Dr. Sven Seldinger described the technique of vascular puncture to access with the catheters to the cardiovascular system. This simple technique continues being one of the bases of cardiovascular intervention, the Seldinger technique. In 1858, Mason Sons, this guy, described the selective sine coronary angiography. And this one, whom you see with him, is Dr. René Favaloro, an Argentinian cardiac surgeon who described the saphenous aortocoronary bypass. This is the machine that at the beginning used Mason Sons. You can see that the X-ray tube is above the patients and the imaging intensifier is down the patient in a hole because the device is too big that need this hole to be placed to be used. In 1966, Melvin Jackins in US developed pre-shaped catheter. The pre-shaped catheter were the basis or are the basis of selective angiography. This catheter popularized the technique and made it easy and can do by everyone. In 1969, Thomas Fogarty, being a student of medicine, described the Fogarty embolectomy catheter. This balloon catheter is the first balloon-basis interventional device and the father of the other balloon for interventions. This is Charles' daughter, named the crazy daughter. The crazy because his advanced techniques are not realistic for this time. He is considered the father of interventional radiology. And probably the most important concept that he introduced is the concept of arterial remodeling. When he treated an 82-year-old woman with a saphenous superficial femoral artery localized lesion with a method that he named de la bruta forza. the expansion of the lesion with progressive diameters coaxial Teflon catheters. He described also many other techniques, and he probably was one of the genius of the interventions. And in 1966, I began my journey. This was my first relation with cardiovascular catheterization. I was in charge of cannulation of the aorta of an Argentinian taught by surgical approach to study the effects of the anesthesia in the blood circulatory constant in these thoughts, naming the bufo arenarum Hensel. In this animal, I began learning cardiovascular catheterization. This is the first cardiac catheterization in which I assist. This is photography. This is real. This is, at this time, I was a student of the third year of the School of Medicine, and you can see there how they work. They are doing right heart catheterization by venous dissection, a brachial venous dissection, and they are with tie, they are without any protection, the asepsia is really poor, and we done the procedures at this time in this condition. You can see too that there are not imaging intensifier, not TV channel, and we look in the X-ray screen direct, putting our eyes and our face over the radiation. This quantity of radiation that I received during more than 50 years take some price in my skin. But the development continues. In 1977, Andreas Grunzig described or do the first in-man balloon coronary angioplasty. At the same time, a man that you can see there sitting was who developed the carotid angioplasty. We are talking about 49 years ago, Dr. Matthias. How many?
45 years ago, I did the first carotid.
Oh, he was.
In April, so it was
okay.
9 months before Andreas Grunzig, so that was September.
September, yes. Well, for that reason, I said that he is a pioneer. In 1987, Julio Palmas, an Argentinian radiologist, described in US the Palmas stent, Palmas balloon expandable stent. And the first in-man case was done by Eduardo Souza, a Brazilian interventional cardiology at São Paulo at this time. Eduardo Souza was who first in-man implant a sirolimus eluting stent in 1999. Juan Carlos Parodi, an Argentinian vascular surgeon, performed the first successful endovascular repair of a triple A, excuse me. we contribute a little in this history. The first, my first publication is Transbrachial Selective Arteriography of the Neck Vessel, published in 1977, and we use a press-shaped catheter to do selective angiography of the neck vessel by the brachial arterial approach. We participate in the study of a percutaneous transluminal myocardial revascularization with a holmium laser and fiber optic transmission, in the development of the Endotech coil stent sheet for the treatment of carotid stenosis, in the usage and feasibility study of the balloon distal protection system for cerebral protection in carotid angioplasty. We do the first in-man cases in carotids, in coronary arteries, with the angioguard distal filter protection. We participate the feasibility, safety, and feasibility study of a probe of IVUS incorporated inside a balloon to control angioplasty in real time. We participate in the feasibility studies of the filter wire protection system for the cerebral circulation. In the development of the front runner and switchback percutaneous coronary and peripheral catheter in chronic total obstruction. In the evaluation of a plug arterial closure system. In the usage of mycophenolic acid to prevent stent restenosis. In feasibility study of the vascular concept peripheral stent graft implantation in peripheral arteries. In the use of nitroxide to prevent in-stent restenosis. In the use of a cell-expanding superelastic and metal endoprothesis covered with a porous elastic system to treat degenerated saphenous vein graft lesion. Really, this history is amazing, but more important too are the developed in the last 2 decades that you sure know better than me. The graft, the branched endograft, the fenestrated endograft, the intraluminal evaluation, physiological evaluation of the circulation, IVUS, OCT, FFR, etc. The description of the systems to treat the calcium, the rotablator, the intravascular lithotripsy, the angiography by MRI and CT, and the valvular endoprosthesis that was developed in the last 20 years. This was really amazing, but I can say that the future is unbelievable. Probably you will see the future. I don't know if I can see it. Then thank you very much for your patience.
Thank you very much. Thank you for everything that you are doing and you continue doing for us. Thank you.
Ivo, you were my best fellow many years ago. Thank you.
Okay, so the first day, half day. Tomorrow we are going to have full day. So thank you for being with us for this for the first day of Balkan endovascular course. Tomorrow morning we are starting in the morning with very interesting sessions regarding the stroke intervention and also neurovascular intervention, 2 consecutive sessions. The second half of the day in this hall is dedicated to aortic diseases and supraortic vessels, aortic and supraortic. And on the parallel sessions, there are several very interesting sessions as well. One of the sessions is dedicated to personal experience of young investigators. And there are several very interesting symposiums about thermography is one of the symposiums. The other one is the software with which we have done our FH trial. This is the so-called parametrization of non-parametric data. And very interesting, 2 simulators. There is also parallel session in one of the rooms with a simulator. Iris Grunwald confirmed she was so kind to agree to teach us regarding step-by-step stroke intervention, endovascular intervention in stroke. So she will start in the morning here, and after the first session she will show to everybody who wants to be taught about stroke intervention. She will be with the simulator, and of course there will be also a poster session for young investigators. So once again, thank you very much for coming. Have a nice evening, and see you tomorrow morning.